Good morning to one and all. Difficult roads leads to a beautiful destination. Even miracle takes long time to happen. A warm welcome to all from me and my team. Good morning, myself Dr. Archana Khare welcomes you all for the FOGSI Presidential Workshop. Today we are going to discuss from RPL to adolescent DUB, even breast health to infertility, and also about the Manyata program and its accreditation. In nutshell, we are have to grab a delicious feast today academics. We will start the program with a lamp lightning. Sometimes things aren't clear right away. That's where you need to be patient and preserve and see where the things leads. And that is the reason we pray, we worship to the God for health, wealth and mental satisfaction. To remove darkness, we lamp the light and for hopes and energy. I request all the dignitaries, please come on dais for lamp lighting ceremony. I request Dr. Anjali Jamma ma'am, Dr. Kundan English sir, Dr. Charulata Bape ma'am, Dr. Rajesh Darde sir, Dr. Bahubali Doshi sir, and Dr. Supriya Jadhav. Please come on dais.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Dignitaries, please stay on a dais till the inauguration ceremony get over. Now I request Dr. Anjali Jamma ma'am, our beloved president, to bless us with her encouraging word.
A very good morning and welcome to one and all. I take this privilege to welcome you all, our esteemed speakers, seniors, teachers and my dear friends. We are lucky to have a FOGSI workshop evolve in Solapur. Thanks to Dr. Rishikesh Pai, Dr. Kundan Ingre, Dr. Bapai madam, in such a short time we have organized this. All of us are well aware of the importance of recurrent pregnancy loss in many spheres. Nearly 15% of women are affected with RPL. Young or old, expert or newcomer, no obstetrician has gone untouched with this. But still, every patient of RPL comes with a new set of challenges and spins us around. Same with even infertility. The beauty of motherhood is not in a reproduction, but in inclusion. To experience another life as a part of yourself and losing a part of yourself repeatedly is unbearable. It is essential to update ourselves with newer developments to save pregnancies and elevate the couples affected with infertility and RPL. Whatever may be the cause, whether metabolic, genetic, hormonal, anatomical, immunological. We will be able to tackle it more efficiently after listening to Dr. Kundan Ingre. In this workshop, we are going to get in a depth knowledge about adolescent AOB, what investigations we should do, whether to start hormonal or not, when to intervene, by Dr. Rajesh Darari sir. And last but not least, we will have insight about imaging modalities for breast disorders. Dr. Charulata Bapai madam will enlighten us on this. Once again, thank you and welcome you all.
Thank you, ma'am. Now I request Dr. Kundan Ingre sir to address the August gathering.
Good morning, everybody. I welcome all of you on behalf of FOGSI and Solapur Obstetric and Gynec Society, and of course my own committee as well as Breast Health Committee as well as Quiz Committee. Evolve and Karya Shala is an initiative by our President Dr. Rishikesh Pai with his theme called Badlav, where we have three important mottos that we use at the Ekikaran, that is we come together. Okay, we are taking a help of Takniki, so we are using a technology, and Samanta, that is all are same, and we are here to take care of our women from India. I think fantastic initiative by our president, and we have lots of these kind of CMEs are happening all across India, and thanks to Alembic team for sponsoring and taking care of logistics of organizing this CME. Most important, I like to place a vote of thanks to Dr. Jumma madam for allowing us to organize with Solapur Obstetric and Gynec Society. Though there was a very tight schedule of the dates, but yes, I think we could organize, and thanks to all of you for being here, and let's learn the academics. That's what is our main intention here, and let's learn the good practice guidelines. So thank you, Dr. Darade, and of course, Dr. Charulata Bapai for joining me here. Dr. Nilesh Balkaude, he is a chairperson of Quiz Committee. He could not join. He is also doing some program in Nagpur, so lots of programs are happening. But I think let's enjoy this day. It's a beautiful day in Solapur, and I think Solapur has it's a basically lovely city, and it's a good venue. So always love to come to Solapur. So thank you very much for being here, and I welcome you all of you again. Thank you.
Thank you, sir, for the encouraging words. I request Dr. Charulata Bapai ma'am to address the August gathering.
Dignitaries on the dais and dear friends from Solapur. Indeed, a pleasure to be in your beautiful city. It is my first time here, and I really must thank our President, Dr. Rishikesh Pai sir, for this Evolve Karya Shala, because of which I have come to this wonderful city of yours. Evolve. You know, we all have to keep evolving. We have to keep moving our cheese. We have to keep modifying things. This is the exact aim behind these workshops, which we are going to be holding all across the country. As far as the Breast Committee is concerned, it is, our motto to train the trainers. You all are the trainers, and it is time that we take the breast back as a gynecological organ, which we have handed over so conveniently to these surgeons. And now we all need to know a lot more about breast health so that we look after our patients in a better way. We all know that the gynecologist is the first point of contact for every woman. And so we need to enhance our skills about breast health. As far as infertility and AUB is concerned, of course, they are our day-to-day, patients. And here we have an esteemed galaxy of faculty who will be guiding us regarding the newer guidelines for the same. I really thank Dr. Jamma for really organizing this conference at such short notice. And thank you, Solapur OBGYN Society, for this honor and pleasure. Looking forward to a great academic session. Thank you so much.
Now we are going to play the video of Dr. Pai sir, our president.
Greetings, I am Dr. Rishikesh Pai, your president of FOGSI. and I'm speaking to you from the lovely island of Havelock in the Andamans, where we are having the FOGSI project on conference. It's a school project, and I'm talking to you from there. I would like to invite you for the first of its kind FOGSI Presidential Initiative Evolve workshops, and this is under the whole wing of the Karyashala workshop, which I am having all over the country. There are going to be many Evolve workshops, and I hope you have a great learning experience. Wish you the very best.
So by the time the PPT gets on, but again, once again, good morning. I think one of the very important and very common problems which we come across, that is recurrent pregnancy loss. And now with lot of advancement and lot of research papers in this particular subject, I think we have all solved roads in front of us for different scenarios, but still there is a scope of optimization, because I think everybody will agree with this point that whenever we deal with a patient of recurrent pregnancy loss, it's again a fresh challenge for that patient, that how our mind should think and what are those important points which we have to take into consideration. So I'm going to present you today optimization, that is how can we maximize our results when we are managing the recurrent pregnancy loss. So give me 1 minute, I will just start the slide. All right, so I hope we can see. Yes, okay. Okay, so this is the best way to describe that what you mean by recurrent pregnancy loss. And this is how a couple, when the first time she gets pregnant, she loses that pregnancy. Again, they try after a few months, again she loses a pregnancy, and again the third time she gets pregnant, again she loses, and that's what is, and they are also fed up, and sometimes as a clinician when we are managing, we are also fed up, and that's the best way to describe. So friends, every day we have the opportunity to learn and experience something and someone new that sees that opportunity from every academic activity, and learn and experience everything you can and use it to change the world. And this is our initiative for this Evolve, that let us evolve ourselves in managing our patients much better way, with much focused objectives and much better strategies which are evidence proof. Now, previous definition, 3 or more losses was recurrent pregnancy loss. Now with 2 losses also we start evaluating. Now these are the 7 broad categories under which we have divided the causes of recurrent pregnancy loss. So genetics, then infections, uterine anomalies, where even congenital as well as acquired pathologies, endocrine disorders, autoimmune disorders, and alloimmune disorders. And I think this is a broad category. We have to keep it in mind when we are managing this patient. Now, optimization, as I said, it is the best that is possible. That is what is optimization. So let's learn that. Again, out of this, all the list or categories or causes, these 5 things, which in fact 4 things which always has to be priority. One is the genetic abnormalities, uterine anomalies, autoimmune factors, and endocrine abnormalities. These are most probably possible causes into recurrent pregnancy loss, though we do have other causes which we are still not having clear-cut literature evidence that it does cause recurrent pregnancy loss. Now, we have to first judge whether it is a first trimester loss or a second trimester loss, and we are going to discuss about first trimester recurrent pregnancy loss. Whenever I see the patient, the first thing what I should notice or note in my history paper about previous losses, and these are the few details of previous losses which we have to keep it in mind. First, whether it was a biochemical or a clinical pregnancy rate. Now, very simple differentiation, that if the pregnancy is documented by a biochemical test like urine pregnancy test or beta HCG, that's biochemical, and clinical is very clearly when you have a documentation by ultrasound about existence of pregnancy, that is minimum of presence of gestational sac. So we first notice whether that loss was a biochemical or a clinical. Then we have to note what gestational weeks it is. So whether it was less than 8 weeks, whether it was between 8 to 10 weeks, or whether it is between or more than 10 weeks. Whether it was spontaneous, whether it was since beginning non-viable, or whether it is missed. Now, important, a spontaneous is something where we have a live pregnancy and there is patient presents to you with a sudden episode of spontaneous bleeding onset. And non-viable is on ultrasound, you have never seen a cardiac activity since the time the documentation of pregnancy is done. And missed is something where with the ultrasound showing a positive cardiac activity, presence of cardiac activity, but later ultrasound showing absence of cardiac activity. Now, before documentation, whether FCA was present on USG is very, very important, because there are two roads, whether we should go by one road, whether we should take another road, that all depends on this particular finding in previous losses. Now, yes, you must note what was given in that ultrasound report. So, you have to note whether it was a sac which was corresponding or no, whether it was intentionally. Many times it has happened that in a gestational sac is just 11 or 12 millimeter, yolk sac is seen, and it is non-viable pregnancy is diagnosed, and we have terminated that pregnancy. We haven't waited whether this pregnancy gestational sac has gone to 25 millimeter, which is the cutoff point where you will see the fetal pole. So sometimes it is, don't take those decisions of termination or advising termination because we just see a small sac. Okay, whether diagnosis followed by DNE, we know that this procedure is associated with certain complications like intrauterine adhesion formation. So we have to note how many times she has undergone dilatation and evacuation. Whether POC karyotype was done and was it genetically normal or abnormal. Obviously, if it is a trisomy or triploidy or monosomy pregnancy, obviously we know the loss of that particular pregnancy loss. Sometimes it does happen that we are seeing 3 losses. Once it is diagnosed that it was genetically abnormal, and 2 times it was some kind of genetically normal pregnancy, but we lost it because of pathology. So again we have to look for pathology for those 2 losses. We may ignore that 1 loss. We know that genetically abnormal pregnancy occurrence or incidence is every pregnancy in her life, it will be 10% genetically abnormal. So that is very important point. So in fact, I always counsel my patients that even we have lost 3 pregnancies, even we have found out any reason, but 4th pregnancy, even you have similar risk of having genetically abnormal pregnancy, there we cannot help her. At the end, decide whether previous pregnancy was viable or non-viable depending on cardiac activity, and whether it was a recurrent presentation of pregnancy loss. Means what? What do you mean by recurrent presentation? It is recurrent presentation of the findings. Now suppose first pregnancy was monosomy, second pregnancy was biochemical pregnancy, and third pregnancy was a second trimester abortion. Again, there is no common cause for these losses, so we have to understand whether every time the reason for loss of pregnancy is different. So it cannot be call it as a recurrent pregnancy losses, though by definition she is RPL case, but when we are trying to find out a cause, it cannot be the same for all the losses. Now let's understand the case scenarios. I tried to make this presentation simple by understanding what we see in our daily routine life. Now in obstetric history, first pregnancy 2014, spontaneous abortion at 6 weeks 4 days. When at 6 weeks, the 4 days prior of loss, sac of 15 millimeter without yolk sac and fetal pole, and then medical abortion was done. Now important point here to note is that there is a 15 millimeter sac, but we don't see a yolk sac. Remember, by 15 millimeter we should see a yolk sac. That is very important. We may not see a fetal pole, but we must see the yolk sac. So it tells me about probability of non-viable pregnancy. Second is missed abortion at 7 weeks. USG at 7 weeks showing me 24 millimeter of gestational sac with presence of yolk sac with a tiny fetal pole without cardiac activity, and then DNE was done. Again here by 7 weeks I don't see a cardiac activity. That is very important again point. Third is 2016 when there was a spontaneous abortion at 8 weeks, but she has undergone 7 weeks ultrasound which was showing me fetal pole with cardiac activity, but fetal heart rate was only 100 per minute, which was very low, like a fetal bradycardia, and again DNE was done. So summary of this, I see in these 2 pregnancies are definitely non-viable. 1 pregnancy is viable, but the fetal bradycardia is present, and twice she has undergone DNE. So what can be the probable causes of all 3 miscarriage? So whenever you see such kind of pictures of 3 non-viable pregnancies most likely. The third one is viable, the fetal bradycardia. Remember, the possibility of almost 80% cases is going to be genetically abnormal embryo. Okay, that is one thing we have to wait. Now I said 80% means there are some 20% which we have to find out. There the uterine problems or endocrine problems comes. So that's how we have to evaluate. Now, investigation to be done in such cases, because we are talking about optimization, is first is a transvaginal sonography, because that is going to tell you what kind of acquired or congenital uterine anomalies are present in her, or probably even looking at ovaries, whether she is a case of PCOS or no. Again, we have to look into homocystinemia, because these kind of features are very commonly associated with hyperhomocystinemia. Must do a glucose tolerance test, because many times all these 3 pregnancies are in the first 6 to 7 weeks gestation. Many times we don't even we don't even screen them for diabetes. Sometimes they are actually diabetics, or they are PCO with insulin resistance. So we need to know about their GTT status. Then thyroid function test, second day FSH LH, again a endocrine, and definitely a parenteral karyotype in this patient. But I have put parenteral karyotype at the end, not the first test. First you have to rule out the common problems, and then comes your parenteral karyotype. So all your first tests are normal, don't leave her without doing parenteral karyotype. Now, what is the incidence? So, almost spontaneous abortions, if you look at the incidence of chromosomal aberrations, is almost in the case, in the percentage of 50%, and in that, the trisomies are the most common, followed by polyploidy. Polyploidy is a triploidy where we have a 69 chromosome set, that is one oocyte is fertilized by 2 sperms, so that's how it is called triploidy. And the third is a monosomic for chromosome X, so 45, that is Turner syndrome. Now, whether cytogenetic studies of the conceptor, should we always do them? I always recommend that yes, even if it is a first loss now, still do the products of conception, microarray or molecular karyotype, because probably you are going to have a cause of that loss. So you can explain the prognosis for the patient that this is a genetically abnormal embryo, and your chances of having a better viable pregnancy in a future pregnancy is almost more than 98%. Again, most common is trisomy, almost in the 66.7%. Now, repeat aneuploidy, how common it is? So, suppose you have a one abnormal conceptus, what is the risk of having another abnormal conceptus in the future pregnancy? And there are 2 studies who have documented that around 10%, so overall it is 15% chance that she may land up in a repeat aneuploidy conceptus. Now, RCOG guidelines are very clear. They say that recurrent pregnancy loss may be due to abnormal embryo which is incompatible with life. As the number of miscarriages increases, the prevalence of chromosomal abnormality in fact goes down. It decreases. So remember that. If the karyotype of miscarried pregnancy is abnormal, there is a better prognosis in the next pregnancy if it is a first loss. And karyotype of the products of conception is a very useful information, as I said, for counseling and future management. What about subsequent pregnancy according to the karyotype of abortus? So these are, suppose if you have odds ratio for a live birth after aneuploidic abortion is almost in the range of 3.28 and 2.62 by these 2 studies. So if you have an aneuploidy embryo, then in fact they have much better chances of a live birth. In fact, if you have a euploidy first conceptus, probably we are missing out some reasons. So in fact, the live birth rate is low. So, that's what is, I mean that first pregnancy, even products of conception, karyotype is definitely important. And what about parenteral karyotype? So if you look at structural genetic factors in either parents, the incidence is only 2.5 to 8% in RPL patients, not in one losses. And the commonest is balanced reciprocal and Robertson translocation, though we have other rare genetic abnormalities also. We will quickly understand the common one, that is reciprocal translocation and Robertson translocation. Remember what is translocation. translocation is there is a transfer of genetic material from one chromosome to another. So part of chromosome is shifted from not X, but for example 14, and it has shifted to 21. That's how it is called as translocation. Now why these two types of, so one is called a balanced translocation, which is basically this translocation is occurring when two different chromosome exchange segments. So they are not like complete chromosome is shifted, it is only the part of or segment of chromosome has been shifted, like what you can see, the here one part has been shifted here. So though we can see two chromosomal pair here and two chromosome here, that is a pair. So we have actually 46 chromosome with two variants. One variation is here and one variation is here. That's called reciprocal translocation, or it is called as balanced translocation, because it is balanced. All the chromosome contents are 46 only still. Now Robertsonian translocation is something which is 45 chromosome with one variant. Now why 45 chromosomes? Like what you can see here, that complete one chromosome has been, it is completely there look at this diagram, from 14 it has one chromosome has completely shifted to 13 chromosome. So now we are missing one chromosome here when we do a karyotype, and that's why it is 45 chromosomes, and we have only one variation that is at 14 number, that is at 13 number. And this is how we have to understand what you mean by balance and unbalance. Now, why, in fact, out of these two, Robertson translocation is the most common, and most exchange happens between chromosome number 14 and 21. That is the most common combination, and that's why a parent who is Robertson translocation, he has a very high risk for developing a Down syndrome because of shifting of one complete chromosomal pair, out of that pair one chromosome to number 21, resulting into trisomy 21. So now 21 has got a 3 sets of chromosome, and that's why with Robertson translocation we always come across majority times trisomy 21. Another very common mishap which happens during cleavage stage of embryo is a non-disjunction. So non-disjunction occurs when chromosome fails to disjoin during meiosis or mitosis, and that's typically a aneuploidic embryo, what we call, or trisomic embryo. Now genetic counseling is very important if you find a abnormal parenteral karyotype, because our colleague genetists are going to help us to predict what are the chances, like whether it is 25%, 50%, 75%, depending on that we can advise our patients whether PGD is must for them. So genetic counseling is really important. Rather than you doing, better to take a help of genetists, because they can give you a very clear idea about percentage wise, and according to the percentage we can offer them treatments like PGD, or even using if it is a higher chances more than 75%, even using one donor gamete can reduce their chances of having subsequent abnormal pregnancy. Now a second scenario where a first pregnancy in 2014 was a missed abortion on ultrasound at 14 weeks gestation. How can a patient reach 14 weeks of pregnancy without having cardiac activity? It's not possible. Right? So definitely this pregnancy had a cardiac activity documentation, and here it was 8 weeks 6 days. Second pregnancy was 2017. The first ultrasound at 7 weeks did show a presence of cardiac activity with the normal ultrasound findings like a normal gestation, but at 11 weeks it showed a missed abortion with absent cardiac activity. Typically this is a viable pregnancy, but because of pathology it has been lost, and that's two missed abortion. Whenever you see these two pictures, two important reasons has to come into our mind, and that is anatomical causes and prothrombotic causes. Anatomical causes, we have septate uterus, intrauterine adhesions, bicornate uterus, unicornate uterus, T-shaped uterus, submucous fibroids, and large endometrial polyps. These are the 7 causes first when it comes to anatomical. Now how do they affect? First, it's basically a very small uterine cavity. That is one of the thesis which has been postulated, like in unicornate uterus. Fewer suitable implantation sites, abrasions of vascularization, so there is an inadequate vascular supply to the endometrium. We know that embryo implantation is something, a communication between a trophectoderm cells and the spiral arterioles. And if there are abrasions in vascularization, we will lose that pregnancy over the time period. May be accompanied by cervical incompetence that may lead to a second trimester abortion. Now, if you look at the Mullerian anomalies, out of all these, the most common one which we can treat and correct is the septate uterus are the most common. Now, if you look at the didelphys, unicornuate or bicornuate uterus, typically what history we will get? We may not do anything for them because these pregnancies, even if after 2 or 3 losses, these uterus can have a full-term 9 months pregnancy. So remember, when you counsel such patients, it is very important that this uterus, though it is present, it may not be the reason for recurrent pregnancy losses, because it may lead to, again, without any intervention, the whole pregnancy can go to 9 months or even at least preterm level. But the correctable ones which are known to cause repeated abortions is a septum, that is uterine septum, and ultrasound, usually the transvaginal ultrasound can give you those acquired causes, especially submucous. Then you have a polyp, you have a intracavitary fibroid, and you have adhesions between inside the cavity. Ultrasound really can give you, because we do have a fantastic machineries now and we can diagnose lot of them. So as I said, first investigation is your transvaginal ultrasound during the first visit. Now 3D has been really a blessing for us when it comes to anatomical causes, that it can give you so clear idea what kind of uterus it is, whether it is didelphys. You can see the 2 cervical canals. This is a bicornuate uterus. This is partial bicornuate uterus. This is septum. This is again, you can see the fundal notch here. This is again a bicornuate uterus. 3D can do, you don't need a hysteroscope or laparoscope to be inserted to diagnose these kind of anomalies. 3D can really give you a good picture. If I don't know, I will send it to radiologist, but get it done. That's very important when we are handling these kind of cases. Uterine septum is one of the very important factor. We have seen that with uterine septum, almost the first trimester abortions are 25%, spontaneous abortions are almost 65%, one of the very common abnormality, Mullerian anomaly associated with RPL, and the documentation of septoplasty results with almost double live birth rate if you don't cut the septum comparison with. So do septoplasty if you come across this kind of, even if it is partial or complete. As I said, bicornuate uterus has got hardly 10% of total anomalies, and abortion rate is only 32%, but they still have a good percentage of pregnancies going beyond 3 months, that is first trimester. Unicornuate is the very tricky one, because unicornuate uterus, almost recurrent pregnancy loss is almost 51%, but again unicornuate uterus again is known to allow pregnancy to grow almost beyond viability also. But cervical encerclage is something which is very highly recommended in unicornuate uterus, because majority of unicornuate uterus, they also associated with a cervical incompetence. So that was about anatomical causes. Let's understand about prothrombotic causes. So we have congenital, that is hereditary thrombophilias. We have acquired thrombophilias. 4 important points. One is a deficiency of antithrombin 3, protein C or S deficiency or low activity, factor V laden mutation, and deficiency of prothrombin variant. These are congenital thrombophilia associated with RPL. In acquired, we have antiphospholipid syndrome and SLE. So that's it. Beyond this, we don't have any much causes left which are really significant. Now, it's very important when you are investigating antiphospholipid syndrome, or you want to rule out that antiphospholipid syndrome, many times the prescriptions which we see is anticardiolipin antibody, LA, that is Lupus anticoagulant, and then it is written antiphospholipid antibody IgM IgG. Now, have you ever gone with the details of the lab that what exactly they do it in antiphospholipid antibody? That doesn't include anti-beta 2 antibody. So remember, do not write antiphospholipid antibody, because it does not evaluate all the antibodies. So you have to specifically write, when you want to write, that LA, typically most better test is by diluted Russell Viper venom test, that is DRVVT. So write LA by DRVVT. That's the important test to be mentioned. Then anti-cardiolipin IgM, IgG and anti-beta-2 glycoprotein. Majority times this antibody has not been tested and it is associated with recurrent missed abortions. So do not forget to write this third antibody, because you will come across a lot of these patients having anti-beta-2 glycoprotein positivity and having other two antibodies negative. So when you see a repeated missed abortion test, what kind of test which we should do, and these are the 6 ones: anti-cardiolipin IgM, IgG, lupus anticoagulant by DRVVT, anti-beta-2 glycoprotein, that is IgM, IgG, anti-nuclear antibody, anti-dsDNA antibody and homocysteine. Homocysteine is a compound which is known as a thrombogenic compound. So in a patient who's got a hyperhomocystinemia, there is initiation of thrombosis into the subendometrial vessels, and because of which there is a loss of pregnancy. And in India, in fact, we are being a vegetarians in majority, probably we do have a very high incidence of hyperhomocystinemia. So in such patients, it has been proven that aspirin and heparin combination works better and significantly improves the live birth rate. Again, this was a meta-analysis in the year of 2010, and it proved that heparin and aspirin is the best combination. Now let's understand one more case scenario. Here a 30 years woman married to 34 years man, and they are married since 5 years. Her cycles are regular. She has lost almost 5 pregnancies. If you look at the first pregnancy was a missed abortion. Again, cardiac activity was present. Again, 8 weeks missed abortion, ultrasound suggestive of non-viable gestation. POC was done. Again, it was a triploidy. So the first and the second loss reasons are completely different. Let's look at the third loss. 7 to 8 weeks missed abortion, cardiac activity was present on previous USG. Then that time she has received with the first loss history of missed abortion. She has received low molecular weight heparin along with SCG in the first trimester. Again, the fourth pregnancy they gave it, but both the pregnancy landed in a missed abortion. Now the fifth pregnancy, this time immunoglobulins was given along with SCG, no low molecular weight heparin was given, that was the history, and only aspirin was given. Again, the pregnancy went on till 18 weeks, but again it was lost. Again it was a absence of cardiac activity, but there was only isolated omphalocele present on the ultrasound. Now if I look at this, it's a 5 pregnancy losses. It has never gone beyond the stage of viability. So investigation, karyotype normal for both parents. All the antibodies were negative. Homocysteine was 8.81. So it was inconclusive. So TB PCR, somebody thought that it's probably tuberculosis. They did TB PCR, that was negative. Now what next? So now we have to think of in these patients to go little beyond. Now in this patient, as I said, anti-beta-2 was never done. So that is the one test which I don't want to forget. Just because she has investigated thoroughly 5 times. Do not forget, look into the investigation. Do that what is not there. So anti-beta-2 is a part of your investigation list. Now you will like to rule out those congenital thrombophilias, that is protein C activity, proteinase activity, antithrombin 3 activity and factor V laden mutation. Now when we got this investigation, we found that protein C and proteinase activity was not very significantly low, but it was on the lower side. Antithrombin was normal, all other antibodies mutation were negative. Now how will you treat this patient? Because I treated her thinking that it is a congenital thrombophilia because the protein C and ACE activity is on the lower side. So what we decided, because there is evidence to it, you give a aspirin, you give a low molecular weight heparin. Now remember, all thrombotic state positive patients, when you want to give heparin, it be a therapeutic dose, and the therapeutic dose is 1 milligram per kg. It is 12 hourly. That is very important. Many times we don't take a step ahead. We think that there is a high possibility of bleeding and we only give it once in a day. No, it has to be 12 hourly. So there are 2 doses. For example, a woman which is more than 50 kg, you give a 60 milligram of low molecular weight heparin twice a day. If it is below 50, then you can go 40 milligram, or if you have a possibility of doing a titration, you can go with 1 milligram per kg as per her weight. But give it 12 hourly. that is very important. We gave it 12 hourly all throughout. Then prednisolone also we added 5 milligram twice a day. You can even give thrice a day because that's an immunological response. We want to suppress that. She had 2 spontaneous conceptions later and continued these 2 pregnancies till term with support of above combination. She never lost these 2 pregnancies in subsequent 2 pregnancies with this combination. And to support this diagnosis, we had this particular study in 2016, and it was inherited thrombophilia patient group. They compared, one group received low molecular weight heparin, one group did not receive low molecular weight heparin, and they found that only giving low molecular weight heparin do not help. There is no significant difference in the live birth rate. So congenital thrombophilia patients, more likely you need additional steroids supplementation to take those pregnancy ahead. Now acquired uterine causes are very simple. You see them and you treat them. So to see, as I said, 3-dimensional ultrasound is very, very helpful, and you can intracavitary, this is kind of a type 1 fibroid, this is also type 1 fibroid, this is type 2 fibroid where majority fibroid is in the intramural portion, that is myometrial portion. Here we do see a couple of small submucosal projecting small fibroids, but 3D is something very important, and submucosal fibroids are very important. So impact on fertility, like about endometrial polyp, that mechanism is poorly understood, but it has been documented that if there is a polyp around, around polyp we have a very affected abnormal cytokine presentation, and endometrium receptivity is very, very less. So, take a help of sonosalpingography, and it has been proven that if you do a hysteroscopic polypectomy, the outcome is more in favor of the patient who has undergone polypectomy, especially continuation of pregnancy. Again, submucosal fibroids, hysteroscopy will give you little idea, but I think your 3D will give you about the type of fibroid, and hysteroscopic myomectomy such patients will definitely be very, very useful. As you can see, this is a type 1 fibroid which is there. Again, I can see the posteriorly type 1 fibroid. Can you see this protuberance here? So that's the type 1 fibroid which is projecting in a large portion of fibroid is inside the cavity. Now, the treatment is very simple for this. Now hysteroscopic morcellation is available, but we do not have, everybody has this fancy, but at least we can use a simple operative hysteroscope, resectoscope with working element with a loop, and we can take care of it. Last quick case where we have 32 years married since 14 years with bad obstetric history. Again, 22 to 38 day cycle. First, she had girl, 8 years, living child. Second, she lost 8 to 9 weeks, MTP was done. It was not a loss, it was intentional MTP. Then third was the 8 weeks non-viable gestation, DNE was done. Now, investigation did show antiphospholipid antibody positive, ACL negative, TSH was 1.9, then semen was normal, uterus was bulky with diffuse adenomyosis, ET was 6 millimeter, irregular with multiple filling defects. Again, though my antibodies are positive, I should not miss this finding. It is very important. So look and do all your thorough investigation. Somewhere you will find your reason. So this was a picture where I cannot see the triple line endometrium. There is an irregularity in the endometrium. There is a hyperechogenicity in certain areas, and that was my concern, that why it is there. Again, she has 2 DNA history. So when I want to investigate such patient, glucose tolerance test, again I don't forget my endocrine problems, antiphospholipid screening, ANA, homocysteine levels, and the most important is a hysteroscopy which will be added into this patient because of that important ultrasound findings. Rest everything was fine. So then we did a hysteroscopy, and then we found that why it was irregular. So it was completely, you can see the thick band of adhesion at the internal os. If you try and pass the office cystoscope through it, then you will see that there are a lot of adhesions inside the uterine cavity. Almost 70 to 80% cavity was completely obliterated by the intrauterine adhesions. And believe me, I think these are the best of the causes because you can treat them. When you see them, you are going to treat them, and your outcome is going to be much, much better. So again, you see these kind of thick adhesions in her uterus, and this is compromising her vascularization, it is compromising her smaller cavity, and again even the implantation is very difficult. Many times when you do a histoscopic adagiolysis, you do a good job, but sometimes you come across, so look at the following scan in the next month after your histoscopic, because again same patient had a recurrence of single band of adhesion, whole of the rest of the cavity was improved very well, but you may have 5 to 6% chances of recurrent adhesion formation in such cavities. So do a good ultrasound in the following month of histoscopic adagiolysis so that you don't want to miss out. Such kind of post-curettage fibrous tissue deposition in the lateral walls, do not miss them. You can clearly see there is a asynchronicity, because if there is a fibrotic tissue deposition into endometrial niche area, the stem cells they cannot proliferate, and you don't have a good endometrial vascularity, and you don't have a good endometrial tissue. What is CMUE? It is one of the classification recently detected, or they have classified how to diagnose T-shaped uterus with the help of 3D ultrasound, where you can see an angle between this line and the vertical line is, if it is less than 130 degree, or if you draw a line from cornu to internal os, and if you measure a distance between this line and till this angle, if it is more than 7 millimeter, or if it is a cornal angle is less than 40 degree, that is CMUE classification for T-shaped uterus. And if the patient presents to you with this finding and you diagnose T-shaped uterus, then you must treat this. How do you improve the low volume cavities, and what are the mechanisms? So take a help of hysteroscopy, do a lateral metroplasty, or you can do a fundoplasty if you have a kind of even a partial septum or arcuate uterus, but correct it, remove that fibrous tissue from that endometrium niche area, so you allow stem cells to proliferate to form a new endometrium and a newer vascularization. Remember up to what depth we can go in lateral metroplasty, so till you see a good vessels at the bottom of your cut area. So because stem cells are lying down on these particular spiral arterioles, and that is why you have to do a good job. Many times we have seen that we cut it superficially, we haven't gone till the vascular stage, we haven't removed that fibrous tissue, so we don't see the much improvement. So do a good job when you do it once also. So always we say that you do one endoscopic surgery, but you do the best job till you see a good vascularization, remove the fibrotic bands into this tissue. And this is how you will see. Now this is the T-shaped uterus. You can see, and look at the thin endometrium, look at the cavity volume, and look at the vascularity. You can see the sparse arterioles. Okay, this is again another view. The peak systolic velocity is very, very less, that is less than 10 centimeter. This is post-histoscopic, similar patient lateral metroplasty done. You have a now fantastic endometrium of 10.5. You have a good vascularity. Your peak systolic velocity is gone beyond 10. Your volume is more than 5 centimeters square. So that is how you can improve the outcomes of the future pregnancies. So don't forget. Endocrine causes, I think, don't forget about LPD. I don't need to tell you how to diagnose, but the most important is the progesterone support, and I think invariably we give all pregnancies after RPL progesterone support, and I think it is important, because many times we are not able to diagnose the luteal phase defect properly because we don't have a proper diagnostic criteria, and that's why giving out of all the list, I think we have natural micronized progesterone and we have a dihydrogesterone, which are the most important. And this meta-analysis clearly showed that if you give a woman with a 3 or more miscarriage, if you give progesterone, they showed a significant decrease in miscarriage rate compared to placebo and no treatment. Which is better drug? Dihydrogesterone. It has got a good Th1 inhibitory activity, and there are a lot of studies which have clearly shown that oral dihydrogesterone definitely reduces, showing a trend that is towards reducing the pregnancy complications like preterm, cesarean, low birth and small for that, and even it reduces the miscarriage. So 2017 ESHRE guidelines says that there is some evidence that oral dihydrogesterone initiated when fetal heart action can be confirmed may be very, very effective into RPL patients. There are papers which have shown that if you give dihydrogesterone till 20 weeks of pregnancy, then mean gestational age is significantly better if you give dihydrogesterone till 20 weeks in a repeated miscarriage patients. How long we should give, that's a big question. till now we don't have an answer. If you look at a pure classical case of luteal phase defect, up to 9 weeks is more than sufficient. But if you have a repeated recurrent pregnancy loss, few papers are there that continue dydrogesterone for 20 weeks. Hypothyroidism, very clearly, it has to be treated. The TSH has to be below 4 before she gets pregnant for the future pregnancy. You treat it thyroxine supplementation. PCOS, why PCOS patients do have a 50% risk of miscarriage? In fact, it has been shown that two important abnormalities with PCOS patient, that is hyperhomocystinemia and also hyperprolactinemia. These are two common abnormalities seen with PCOS patient, and in fact that's why that increases the risk of repeated miscarriage into PCOS patients. So thank you for the patient hearing. I hope I could clear some of the points, and you can take those points for your good practice. Thank you very much.
Thank you, sir. I request Dr. Anjali Jama ma'am to please felicitate Dr. Kundan sir. I request Dr. Rajesh Darade sir to talk on adolescent AOB management. Dr. Rajesh sir is endoscopic surgeon from Latur. He is a chairperson of endoscopy committee AMOX 2020-22 and author of book Manual of Maternal Mortality. Over to you, sir.
Thank you, madam, for your kind introduction. Good morning, everyone. Respected Dr. Anjali Jama madam, President of Solapur OBGY Society, Dr. Archana Khare madam, who is Secretary of Solapur OBGY Society, my friend Dr. Kunda Nigre from FOGSI, Dr. Bapaya madam from FOGSI, and all dear friends. Today I will be speaking on adolescent AOB management. Abnormal uterine bleeding, that is AOB, describes a range of symptoms such as heavy menstrual bleeding, bleeding above the 95th percentile of the normal population, intermenstrual bleeding, and combination of both heavy and the prolonged menstrual bleeding. This terminology was established by the International Federation of Gynecology and Obstetrics, that is FIGO, Menstrual Disorders Working Group in 2011, and has been gaining the global acceptance for this. This is a routine topic. All of us, we come in our practice, day-to-day practice. Adolescents may also experience abnormal uterine bleeding due to immaturity of the hypothalamo-pituitary ovarian axis. Menarche is generally anovulatory bleeding, and HPA axis maturation following the menarche, which is thought to result in anovulatory cycles, and subsequent regular bleeding varies between 6 months and 3 years. Additionally, this population may also have underlying endocrine disorders as mentioned by Kundan, that is polycystic ovarian syndrome, hyperprolactinemia, and the thyroid disorders. Heavy menstrual bleeding may affect quality of life, so the most important goal is to elevate the anxiety of the affected girls and their families and to indemnify the underlying medical conditions. This is usually the normal menstrual cycle. Mature follicle is 2 to 2.5 centimeter. Corpus luteum is around 1 to 3 centimeter size. Endometrial height is ranging from 3 to 14 millimeter. Average menses like estrogen plus progesterone withdrawal causes usually is for 5 days flow. Volume is around 30 cc. Average cycle range is 21 to 35 days. Now, definition: change in frequency, duration, and amount of menstrual bleeding. Any bleeding that is not regular cyclic menstrual flow. That may be like intermenstrual spotting, postcoital bleeding, excessive heavy bleeding, and unpredictable bleeding. Now, menorrhagia, this adolescent menorrhagia occurs in 9 to 14% of the healthy women. Most common gynec disorder of reproductive age in the women. Abnormal uterine bleeding, that is International Federation of Obs and Gynec Society recommendation for the menstrual terminology, like disorders of regularity, disorders of frequency, disorders in the amount of the flow, and disorders of the duration of flow. So there is a palm coin classification. Now the palm is structural causes like polyp, that is labeled as AUBP, adenomyosis, there may be leiomyoma, submucosal or intramyolar fibroid, as Kundan has nicely showed the video, then malignancy, and the coin classification, there is maybe coagulopathy, ovulatory dysfunction, there may be endometrial cause, iatrogenic and not yet classified, that is AUBN. Now this AUB may be like acute and chronic. Abnormal uterine bleeding can also be divided into acute and chronic cases. Acute AUB is excessive bleeding which requires immediate intervention to prevent the further blood loss. Acute AUB can occur on its own or superimpose on the chronic AUB, which refers to the irregularities in the menstrual bleeding for most of the previous 6 months. 55% of the cycles in the first year are anovulatory, usually at least 15 months from menarche to achieve 10 cycles, while normal fertile in adults, there may be 1 or 2 anovulatory cycles and 10 to 12 cycles per year. Now in adolescent, menstrual pattern ends usually 2 to 3 years after the menarche. This is usually in the normal cases. Now 10% with menorrhagia will have a coagulopathy. Most common etiologies are ITP, von Willebrand's, Glanzmann's and thalassemia major and the Fanconi's anemia. Tests usually we do INR, PTT, bleeding time, platelet count and the von Willebrand screening is done for this. Now what are the causes of anovulation? Physiologic causes like adolescence, perimenopause, lactation and the pregnancy. There may be pathologic like hyperandrogenic cases, hypothalamic, thyroid disease. There may be primary pituitary to premature ovarian failure and the medications. Now PCOS usually affects 1 in 9 women. Most common cause of anovulation. Diagnosis usually do by history like oligo or anovulation with one of the evidence like evidence of androgen excess. There may be polycystic ovary on sonography. Begin in the teen years or early 20s. Multifactorial inheritance associated with insulin resistance and the metabolic syndrome. There may be family history of type 2 diabetes. Hypothalamic dysfunction may be hyper or hypothyroidism, like age factor in screening more than 35. Hyperprolactinemia, the patient may come with amenorrhea or the hypomenorrhea in 2/3 cases. There may be galactorrhea present in 1/3 cases. Infertility with normal menses, need to repeat after the 48 hours and level more than 50 needed to consider the MRI of the sella turcica. CNS suppression, low FHS and LH may be there. There may be stress, most common cause of this. There may be anorexia, athletic, low suppression, higher estradiol, more suppression, hypoestrogenic, and rare congenital absence of LH or the mutation in the gonadotropins or GnRH. Now, coagulation disorders may be there. Most common causes are ITP, von Willebrand's disease, thalassemia major or Fanconi's anemia. Now, test for this bleeding again INR, PTT, platelet count, von Willebrand's screening is done. Von Willebrand disease is the most common inherited bleeding disorder with a frequency of 1 in 800 to 1000. In adolescents, around 10% will have a coagulopathy, usually ovulatory cycles with a severe menorrhagia. Tranexamic may be the benefit for these cases. We'll come near the later slide, management cases. There may be chromosomal disorders, suspect if initial normal cycles, then irregular amenorrhea, and evidence of diminished ovarian reserve. Less than 25 years, then maternal mosaic more likely. Later in 20s, early mid-30s, diminished severe associated with the fragile X or premature mutation, or on the older end BRCA1 mutation. If mutation and some reserve left, consider ART options for these cases. Now, what are the iatrogenic causes of AUB? There may be intrauterine device, oral and injectable steroids patient may be taking, or psychotropic drugs patient may be taking. So because of this also there may be AUB. Now differential diagnosis of abnormal uterine bleeding can be divided into like endocrine, bleeding disorders, pregnancy, infections, uterine pathologies, any medications or the trauma. Now in this such cases, quality and quantity of bleeding is important. Detailed history how to take, what type of protection, frequency of change, and the established current complaint, what patient is complaining of. Like other symptoms such as cramping, dyspareunia may be there. So evaluate use of medications prescribed as well as OTC and the herbal supplementation. Now, evaluation workup of such cases, thorough, I already mentioned thorough history you have to take, screen for eating disorders, and lab tests also, as mentioned here. Then HCG, LH-FSH ratio, CBC, thyroid stimulating hormone, cervical cultures also done. Ultrasonography is very important, sometimes histoscopy. Now, what is our goal of management of this AUB in adolescents? Goal is to achieve individual and the therapeutic goals, that is control bleeding. So we can think of contraception, underlying medical conditions has to be treated, tolerable side effects, and improve the quality of life of the patient. That is by NICE guidelines. Now, what are the different drugs we use? We commonly use like non-hormonal drugs like non-steroidal anti-inflammatory drugs we use, antifibrinolytics, then hormonal combined oral contraceptive pills we routinely use in our practice. There may be levonorgestrel releasing intrauterine devices or systems. Oral, sometimes we use oral progesterone, that is long phase, day 5 to day 26. Sometimes we use depot medroxyprogesterone acetate and danazol. And newer options like modified release tranexamic acid can be used. Then quadriphagic COC, combined oral contraceptive pills, that is estradiol, valrate and dinogest. Vagina danazol also can be used for such cases. Now, LNG intrauterine system, first line of treatment of AUB, this was in NICE guidelines in 2017. Medical, also there is medical therapy versus surgery. So all this LNG intrauterine device is better than other medical therapy, has better outcome like around 64%. Now, what are the contraindications for these LNG intrauterine systems? History of recently sexually transmitted diseases, undiagnosed uterine and vagina bleeding, distorted or small uterine cavity, genital malignancy, active trophoblastic disease, PID, marked immunosuppression, current history of DVT or pulmonary embolism, ischemic heart disease, there may be active viral hepatitis, breast cancer within a preceding 5 years. So, these are the indications where you don't use these LNG intrauterine systems. Now, second, tranexamic acid, this is the second line of treatment in AUB. This also including the NICE guidelines 2007. By this, blood loss is decreased by almost 34 to 54%. Norethisterone also can be used. No effect on the duration of the bleeding, less GI side effects, and dose is usually 1.5 gram 3 to 4 times a day can be used. Now, what are the adverse effects? Sometimes, most of the times there are no like major side effects, but sometimes there may be like a nausea, vomiting, diarrhea, increased thrombotic tendency like DVT when thrombosis, prolonged treatment as with any fibrinolytic inhibitors. Contraindication is usually severe renal insufficiency, active intravascular clotting, thromboembolic disease, and the color vision disorders. These are the few adverse side effects of this. NSAID is more effective than the placebo in reduction of the menstrual bleeding, but less than tranexamic acid and the LNG intrauterine system. So, no individual variations among NSAIDs and the comparative to oral contraceptives and the progesterone. So, usually with this reduce blood loss by 20 to 30%, reduce dysmenorrhea by 70%. If no relief, stop treatment for 3 months and then again start a day before menses and continue for 3 to 5 days. This is also mentioned by the NICE guidelines. Now, progesterone, oral luteal phase progesterone does not produce significant benefit. That's one of the study. But usually norethisterone 5 mg TDS. This regime is from day 5 to day 26 of day. Injectable DMPA also can be used, though used practically, but no published trials on the AUB. Combined oral and injectable DMPA stop bleeding within 2.6 days of the starting the injections. Noil quadriphagic estradiol valate also can be used for this AUB. Dinogest 2 to 3 mg 28-day pills, better cycle control with this strict regime. Complex interchange mean blood loss is decreased by 88%. Reasonable choice to reduce and control bleeding in this case. More likely to benefit for unavoidable bleeding. Combined oral contraceptive can cause AUB. This was one of the Cochrane study in 2009. But combined oral contraceptive is really good, and that usually patients are very happy with this COC. So, overall reduced blood loss by around 44 to 50%. Vagina danazol. This now does not affect the hypothalamo-pituitary ovarian axis. Direct effect on the endometrial cells DNA synthesis. There is high uterine in the ovarian concentration. vaginal irritation, only adverse effect with this vaginal danazole, significant reduction in the blood loss, dysmenorrhea and dyspareunia. Now, GnRS also can be used to achieve short-term relief from abnormal bleeding. Patients receiving a gonadotropin-releasing hormone agonist for longer than 6 months should be prescribed add-back hormone therapy if not already initiated with the gonadotropin-releasing hormone. Now, desmopressin is indicated in patients with thromboembolic disorders, has been used to treat abnormal uterine bleeding in patients with coagulation defects. Transiently elevated factor VIII and von Willebrand's factor. Now, management of mild to moderate uterine bleeding. When the patient comes to the OPD, most of the times they are like mild to moderate cases. In such cases, adolescents with mild or moderate bleeding with a normal HB level, reassurance with the observation is sufficient. If the hemoglobin is in the range of 10 to 12 gram per deciliter gram percent, observation or OCP are valuable therapeutic options, and along with that, we add 60 milligram daily iron supplementation for the treatment should be commenced. In the presence of moderate bleeding or HB levels in the range of 8 to 10 gram percent, treatment should be continued until the HB level is above 12 gram percent with at least 6 months of the iron supplementation. Now, in the presence of contraindication to the estrogen therapy or alternative treatment in adolescents with anemia, progesterone therapy such as norethistone acetate 2.5 to 5 milligram per day is an option which should be given for 12 days in every cycle. Now, management of severe uterine bleeding or in adolescents. Adolescents with active profuse heavy bleeding changes more than 1 pad per hour. So, presence of vital signs in conjugation of the evidence of hypovolemia, orthostatic hypotension or hemoglobin level is very less than 8 gram due to bleeding should be hospitalized. Now, if the patients can tolerate oral intake and in the absence of contraindication of estrogen treatment, hormonal therapy is initiated and can be used every 6 to 8 hours until bleeding diminishes, then taper to 2 and then 1 pill per day. Now, most adolescents respond well to hormone treatment and iron supplementation also tolerate anemia better than the adult. So, after cessation of bleeding, transition to maintenance of the treatment is required in such cases. Now, management is severe uterine bleeding. High dose estrogen treatment can induce nausea and vomiting requiring prophylactic antiemetic agents in such cases. During the maintenance period, hormone therapy should be continued until the HB level increases or for longer in the presence of underlying bleeding disorders. In adolescent girls with contraindication to estrogen containing regimes, I already mentioned, progesterone in the form of oral norethistone acetate at the dose of 10 to 30 milligram per day and tapering should be begun after bleeding diminishes. Then you can start with 1 OD, 1 BD, afterwards maintenance dose. In girls who have menstrual bleeding under control, iron support is usually sufficient for 3 to 6 months. Now, treatment of anatomical function, like anatomic causes, treat that anatomic causes, usually bleeding, most of the times bleeding controlled with that. If not, like hormone issue, thyroid dysfunction, as Kunal has mentioned, treat the thyroid, resolve AUB once the normal thyroid functions are there. Once you start antithyroid, then usually patient responds and the AUB is controlled. Hyperprolactinemia, treat with cabergoline or bromocriptine. When prolactin level is normal menses are there within 1 to 2 cycles. If unable to treat cause, then cyclical progesterones or the hormonal contraceptives is the best treatment. Treatment of menorrhagia, as usually mentioned, suppose there is usually extremes of menstrual ages, this usually rule out pregnancy, trauma, coagulopathy is already mentioned. Sometimes there may be high dose of conjugated estrogen, usually don't give in these cases, but sometimes you can use this. This is a flow chart, care pathway of women presenting with heavy bleeding in all the ages adopted by the NICE guidelines. Yeah, now usually is norethistone, this is up to 83% reduction of the bleeding when you start norethistone. Side effects are all transient and reversible. There may be slight weight gain, bloating of the abdomen, breast tenderness, headache and acne. This can be resolved with symptomatic treatment. To summarize, AUB in adolescents may be acceptable at the beginning of the reproductive age when a menstrual cycle irregularity is not established, or may be the first sign of severe bleeding, underlying bleeding disorder. Girls with AUB should be evaluated with care and wide differential diagnosis and should be borne in mind. Medical therapy is usually an effective and sufficient treatment. Non-ethistone is a progesterone that has strong progesterogenic characteristics as well as the tissue-specific androgenic, anti-estrogenic, anti-gonadotrophic, and the estrogenic properties. Norethistron is an efficient progesterone and also has a beneficial effect on BMD with minimal effect of lipid and glucose metabolism. According to risk efficacy audit study, the use of non-estrogen is an effective and the reliable treatment option for adolescents with acute AOB, where controlling severe uterine bleeding is desired. Thank you very much for the patience hearing.
Thank you, sir. I request Dr. Jamma ma'am to please felicitate Dr. Rajesh Darade. For our next talk, I invite Dr. Kundan Ingle sir for the talk of evidence-based strategies on poor responders management. Over to you, sir.
Sorry, okay. Right. Okay, we are going to discuss about poor responders. So, one of the very important patient groups, group of patients in infertility. Yeah. So, poor responders definitions have been studied over the years now, and one of the best way to describe this group of patient is described by Salam in 2005. That least number of oocytes retrieved below which the clinical pregnancy rate is significantly diminished compared to those patients from whom a higher number of oocytes is retrieved. So that is the main problem with poor response. So we don't have any cutoffs where we get only 3 oocytes or 4 oocytes or 5 oocytes. So below which we don't have a very poor pregnancy rate. Now incidence, if you look at in our OPD nowadays, what we see is around 9 to 24%, but I think it is more than now. Nowadays we see more of these patients, and the graph is increasing only. So there are various etiologies, like suppose a Rizzo can be poor due to the age, that she's elderly patient, more than 38, 39, 40 age group. So probably age is one of the associated finding with low ovarian response, low ovarian Rizzo. Then abnormal FSH receptor gene polymorphism. I think this is one of the very important reason, especially into young poor responder patients. Then ovarian antibodies, reduced aromatase activity, decreased blood flow. So there are certain pelvic pathologies which interfere into ovarian blood supply, and because of which the ovarian reserve has been decreased and she is responding poorly to your ovarian stimulation. And then you have acquired factors like obesity, ovarian toxic chemotherapies or radiotherapies, surgeries, infections, endometriosis, and heavy smoking. So these are the different etiologies for which we are keep seeing now a very large number of poor responder patient. Now previously in 2011, ESHRE consensus criteria was very clear that at least 2 of these criteria, if they are present, then it is called as a poor responder. If it is an advanced maternal age, more than 40 years, if previous oocyte retrieval has given less than 3 oocytes, and abnormal ovarian reserve tests like antral follicular count and the anti-Mullerian hormone. But since 2014-15 onwards, we are using a Poseidon classification. Now Poseidon is patient-oriented strategies encompassing individualized oocyte number. So depending on how many number of oocytes we are getting and age, this is how they are differentiated into 4 categories. Now this is very important diagram, because according to this group, our management strategies are changing. Now look at this purple line. Above this purple line, we have a patient group who's poor responder but having adequate ovarian reserve. So she has a good reserve. She should have responded much better. but still she has responded badly. So that is adequate ovarian reserve group. Now again, young and the old, that is what is the vertical line. This side of blue line is a young and a older, that 35, below 35 and above 35. And the below purple line, these two groups, those are grade group 3 and group 4, those are having poor ovarian reserve. Obviously their reserve is very poor, they are going to respond badly because of the poor ovarian response. Again, there are two age groups, young and the old. So the poor ovarian reserve patients are typically, if it is because of age, that is above 35 and having a poor ovarian reserve. So those are the poor ovarian reserve patients. Now low prognosis group, that is different strategies. In all these patients, whole objective is to achieve pregnancy. Now what is difficulty we come across in these patients is to get adequate number of mature oocytes. That is one thing which we are facing a problem. And not only that, to get a good quality oocyte, to get at least one euploid blastocyst which can give rise to pregnancy. So it is a quantitative as well as qualitative low reserve or low response. Now what is expected poor responder? Now expected means why we expect that she will respond poorly, because her reserve is poor. So poor ovarian reserve patient, that is below that purple line, that is group 3 and group 4, these are expected poor responder. That is what is the terminology is used, that is group 3 and group 4. Now a systematic review of the test predicting ovarian reserve and IVF outcome. So we have AMH, antral follicular count, but I always feel that let's not take them as a final red line investigation, but undergoing the first cycle of IVF without any prior testing seems to be a preferable strategy, because many times it does happen that we do see a less antral follicular count. The moment we start stimulation, they give you 8 or 10 oocytes. How can we call them poor responders? So that's the whole thing. So undergoing first IVF cycle should be the better way to say that this is a poor ovarian reserve patient. I'll come directly on the management plan. We have to understand again the evidence-based strategies. So any pre-treatment, so before we plan IVF for this patient, now you will ask me why we are talking about IVF for this patient. So if you look at the evidence that if you do a IUI with a poor ovarian reserve patient, the results are also that poor. Anyway, with normal ovarian reserve, IUI pregnancies are not more than 10 or 12%. With poor reserve, that incidence of pregnancy with IUI goes below 2%. So that's why best treatment which has been suggested for after diagnosing poor reserve patients is IVF. Now, how can we optimize the result? That objective to get good number of oocytes, and also the objective is to get a good quality oocytes. So that is, we have to keep it in mind about the focus about that. So pre-treatment option, we have 10 adjuvants. Now we have 10 adjuvants. Can we bombard patients with all 10 adjuvants? We have to understand what is better, what is best in this till now by the evidence, and then only we should include. The most common, the first are androgens, that is testosterone and the DHEA, and then we have lot of other adjuvants which we'll quickly go through. Now this was in 2016, this study where a group 1 patient received DHEA 3 times a day for 12 weeks before the IVF FOGSI cycle for these patients, and second group did not receive DHA. Again, remember, it's a randomized control trial, and if you look at the DHA increases the number of oocytes. You can see here, look at the p-value, significantly better when they receive DHA. Fertilization rate, fertilized oocytes and clinical pregnancy rate, again if you look at 32 versus 15.7%, again p-value is significant. Ongoing pregnancy rate is also much better when you supplement DHA in women with a poor ovarian reserve. So one of the good study, because lot of confusion was there that whether androgen really works. So only one randomized control trial has been done, and that has given this response. Now this was another randomized clinical trial in 2020. Here the study group took DHA supplementation, again TDS, for 2 consecutive cycles before induction of ovulation, and they found that DHA may help many poor responders to, so better considered for poor responder patients. It definitely showed a significant improvement compared to control group. The outcomes in the study group showed a statistically better response than the control group. So giving androgens, now why androgens plays an important role, we have to understand that for a oocyte maturity, there is a adequate amount of androgens are required in the follicular fluid. So it has been seen with the poor ovarian reserve patients that their follicular fluid has got a lower concentrations of androgens, and that's why their quality is poor. So if you supplement them with androgens, the follicular fluid androgen levels increases, oocyte maturity increases, and thus you get a better oocyte quality. Now, another study which was a meta-analysis in 2014, this time they wanted to study what about transdermal testosterone for poor ovarian responders, and they found that there is a twofold increase in live birth rate, clinical pregnancy rate, and significantly more oocyte retrieved. This was a meta-analysis in 2014. Then 2018 we got this single blinded randomized clinical trial, again a better study, but only problem was less number of patients, only 25 patients in each group. Again they showed that if you use transdermal testosterone gel, there is a significant impact on the fertility rate in these patients, especially in IVF cycles, but they expect that the larger sample size studies are recommended. So some evidence has been there for androgens to be used. They make a significant change into this group. Now, other than androgens, this particular meta-analysis in 2020, that list which we saw for 10 or 15 adjuvants, out of them, DHEA, CoQ10 has been proven are the best for poor responders than any other drugs. Okay, it is mentioned here even growth hormone that resulted in the highest estradiol level on the SCGD. Are we worried about estradiol level in poor responders? Never. We are only worried about number of oocytes and quality of oocytes. So in keeping these two objectives, two adjuvants are really good, which we should add before IVF, and that is DHEA and CoQ10. Now this was a good meta-analysis which says that if we consider the low level of evidence of some of the included study designs, the lack of evidence-based protocols for both DHA and testosterone supplementation, the heterogeneity in the definition. We have lot of confusion when these studies were done. Eshrei criteria was used. Before that, there was a variable criteria. So that was there was heterogeneity in the definition. So selection of the patients were poor. There was diversity in the IVF protocols, and because of which all previous studies for androgens were not so encouraging or giving us encouraging results to be used. So this particular study in 2021, they say that the bulk of evidence is still limited. So probably it's better that we restart this chapter with a well-designed clinical trial. So whatever we say that probably it doesn't work, but probably we don't have that good evidence. So now stop thinking about it. Let's start a fresh start and do a good clinical trials. And there are trials which are coming ahead, and but there are few studies which I mentioned are in favor that androgen really gives us a better results. Now coming to the next strategy, the second step of IVF, which is a ovulation induction protocol for this expected poor responder. The best protocol is an antagonist protocol. You start on the second day with HMG or recombinant FSH. Give it for 8 to 9 days for follicular development, but you add antagonist on 5th day, which is a fixed dose protocol, or flexible protocol where when the follicles reaches 14 millimeter, then you start antagonist. So that is considered still now a gold standard protocol for poor responders. Now there are patients who will show you a asynchronous growth during antagonist protocol. So first of all, we are going to struggle for number of oocytes. So if we see a asynchronous growth during antagonist protocol, stop the cycle. That is something bold step, we should do it, and go for a GnRH agonist day 21 protocol for such patient. Probably there are not too many patients, maybe 10 or 20% patient of poor responders who will need this protocol. But for any asynchronous growth where you expect that if I continue my stimulation and if I am going to get only 2 or 3 oocytes, probably stop there, and you can go with the GnRH agonist depot protocol, because here you are down-regulating the pituitary. So there is no FSH in the circulation at the start of the cycle, and whatever dose you give, there is a synchronous selection of follicles as well as synchronous growth. The only one problem with GnRH agonist, the number of days of stimulation is going to be little more. maximum 1 or 2 days. So 1 or 2 extra doses of gonadotropins are going to be there, but it's no problem if we are getting more oocytes instead of having 2-3. If I am going to get 5-6, it's going to make a lot of difference. For poor Rizzo patients, I think getting one mature oocyte also makes a lot of difference. So do not hesitate to cancel your asynchronous antagonist cycle and shift her for the day 21 protocol, where she will give you a much better. What about the evidence? What evidence says for poor responder? Again, it's a randomized clinical trial in 2013, and it did show that long GnRH agonist and FIGS antagonist protocol seems to have a comparable pregnancy rate. Both are good. Now, then why only antagonist first? Of course, the number of injections are less. That's number one, and you do not have that early follicular phase pituitary suppression which is present in GnRH agonist protocol. So those advantages are going to be there always. So there is no change in the pregnancy rate. As I said, there is an absence of initial pituitary suppression in the follicular phase. That's why antagonist is much better. Even there is no difference in the clinical pregnancy rate between agonist and antagonist into these poor ovarian responder patients. So clear advantage is that we have a better results with antagonists, only except duration of stimulation is slightly more with agonist, shorter with the antagonist. Now, if you look at this randomized control trial in 2014, it is showing comparing the GnRH agonist day 21 protocol versus short agonist versus antagonist. So all three protocols were compared. What they found that agonist day 21 protocol giving me much better number of oocytes, of course, but if you look at the ongoing pregnancy rate, it is more with antagonist. So antagonist is the first protocol. Again, antagonist is the first protocol. If you come across a asynchronous growth, stop and go back to the day 21 protocol for those 15-20% patient. So this is our second strategy. Now, can we synchronize this? Can we avoid this cancellation of cycles? So one of the very good strategy, the moment you know this patient is a poor responder and I don't know whether she will respond asynchronously, how can we avoid this cancellation? So the pre-treatment with estrogen in the luteal phase. So what you do, on day 21 of the previous, day 25 of the previous cycle, you start giving her tablet estradiol hemihydrate or valerate 4 milligram per day, that is 1 BD tablet, and give her continuously till she gets her menses. Like poor responders, they may not have an anovulatory problem, so they may have a regular cycles. So you start on day 25 of previous cycle, give it till she gets her menses. Now she is a regular cycle patient, so she is going to get her menses even if you are going to give her estrogen, because that is going to be because of progesterone withdrawal. So giving estrogen will not prevent her getting menses. So give continuously till she gets her menses and continue estrogen till the second day of menses when you are going to start ovarian stimulation. So the moment you start ovarian stimulation, you can stop that estrogen. Now this estrogen is going to suppress that FSH, which is actually getting secreted early in the late luteal phase, which is causing asynchronous follicular growth. So it has been shown that that there is this particular protocol is having, again like GnRH agonist, having higher duration of stimulation, but higher number of oocytes retrieved and higher mature oocytes are retrieved and lower cycle cancellation rate. So without compromising in the clinical pregnancy rate. So this is one of the another good strategy. So whenever you diagnose, put it on the paper that I have to give her pre-treatment estrogen, which is going to help me. Now, what dose of gonadotropins for poor responders? Shall we go for very high dose or shall we go just for a fixed dose? Again, it has shown that in a woman with predicted poor ovarian response undergoing IVF, increased FSH dose does not improve cumulative live birth rate as compared to standard dose. So that is what has been given by this study. But if you look at the starting dose of this patient group, where you starting dose, whether should we give 300, 450, 600 IU. Please remember, these studies have used recombinant FSH hormone, okay? And they showed that even if you give 300 starting dose, you do not have a significant difference in the clinical pregnancy rate. So the starting dose for poor ovarian Rizzo patients, if you are starting, then if you are using recombinant FSH, it has to be 300. If you are using HMG, it has to be 450. Okay, because that's 95% pure hormone. But many times it is confused, and HMG 300 is started because that is sometimes a lower dose. So when it is HMG, it has to be 450, recombinant FSH is 300. Now can we use recombinant LH in this group, and where to be used? Recombinant LH only should be used in patient where you are using recombinant FSH in the first follicular phase, initial follicular phase stimulation. Now why do you need that LH? Of course, we know that LH stimulates androgen production, so it enhances follicular androgen production. We just discussed that we need a better androgens in the follicular fluid and also aromatization to estrogens. So by giving recombinant LH, we have a better androgen levels in follicular fluid, and also we have a better estrogen levels. So definitely giving addition of LH. But where exactly and which group we should give according to the Poseidon criteria? So this was a 2018 systematic review. 6 clinical scenarios for poor responders were selected, and then they were studied and compared, and they found that only recombinant LH supplementation is beneficial only in 2 scenarios, only given those scenarios, where women with adequate pre-stimulation ovarian reserve parameters, means Poseidon criteria group 1. Okay, and she has unexpected hypo response to recombinant FSH, means you have a patient who is less than 35 years old, you have started a stimulation with recombinant FSH, after 4 days of stimulation, 5th day, when you see that follicles are not even 10 millimeter, they are 7, 8 or probably 9 millimeter, nothing is beyond 10 millimeter after 4 days of stimulation, then those are the patient, there instead of cancelling, you continue recombinant FSH but add recombinant LH, and there you will see that within 72 hours her follicles will speed up and will come up and will give you much better response. Then second group, where a woman with 36 to 39 years of age, again elderly poor responders patient, you add LH if you want to use a recombinant FH. Is there any substitute for it? Of course, the HMG can be the substitute. So if you are using a recombinant FSH, you don't want to spend more money on recombinant LH, you can add just HMG 150 as a substitute for recombinant LH. Probably you will get a similar results. What about growth hormone? We initially understood. Now growth hormone itself increases follicular insulin, or insulin like growth factor 1, which actually improves the response to gonadotropins, also increasing the oocyte competence and possibly increasing the DNA repair capacity in the oocytes. We know that oocyte has got its own repair capacity, so that is actually growth hormone does. This was a mechanism for which we used to use growth hormone. Years together we used it for almost a decade, but then recent studies in 2019, double-blind, placebo-controlled, randomized clinical trial, I think one of the best way to do study any drug, that proved that there is no change in live birth rate, and that's why last 3-4 years we have stopped using growth hormone. That mechanism for which we were wanted to use it, it is not proving and giving us a ultimate outcome of pregnancy. What about double stimulation in poor responder? I think this is one of the area probably in future we might start using it, but it's a little costly affair. What we do one stimulation in the follicular phase. After the first oocyte retrieval, 72 hours later we start the second stimulation, similar manner with antagonist protocol, and we do a second pickup. So in one cycle we are doing 2 oocyte retrievals. It has been shown that particularly the luteal phase stimulation, that second phase stimulation, is giving you higher mean number of oocytes. The competence is much comparable in both the stimulations, but rate of patients obtaining at least one euploid blastocyst is increased from 42%, which is seen in follicular phase stimulation, to 65% with the contribution of luteal phase stimulation. So if double stimulation strategy used, chances of getting one euploid blastocyst is almost double instead of doing only one stimulation. So if you see first stimulation and if you see that, okay, I got only 2 oocytes, but this patient may give me another 2 or 3 additional because I do see small antral follicles there, I can go for second stimulation, and in the same cycle I get more oocytes and more embryos. So the chances of having more embryos to transfer in my hands are more better. Now whether ovulation trigger, what should be the ideal dose? Now, the only two triggers are there. One is SCG, second is the GnRH agonist. It has been seen that if you give SCG along with GnRH agonist, then everywhere the number of retrieved oocytes, metaphase to oocytes, total embryos, number of transfer embryos, your chemical pregnancy rate and clinical pregnancy rate, all are significantly better and are in favor of dual trigger. So the IVF outcomes are better. So there is SCG, there is a endogenous LH. Both of them causes much better cytoplasmic and nuclear maturation of the oocyte, and that's why we get a better quality oocyte, and that's why the outcomes have improved. So dual trigger always for poor responders. Now, natural cycle stimulation, there was a group of minimal stimulation who were discussing that we are getting much better results, but I think the studies over the time period, they said that there is no change in the live birth rate, there is significantly reduced live birth rate per cycle and per treated patient in patient who has used natural cycle IVF. So we don't want to use natural cycle IVF. What about pulling of oocytes? So I did one stimulation, got some 3-4 oocytes and one embryo. Then after 3 months or 2 months, I did second stimulation. So I have gathered the oocytes and then did a transfer. Again, this is not a very beneficial strategy on live birth rate especially. So it's not adding any value addition for my treatment. Again, it's a very strategy which was used for a while, and then with this kind of 2018 papers, it was not so great results. Frozen embryo transfer versus fresh embryo transfer. We know that frozen embryo transfer has an advantage because it is the embryo which is frozen is been transferred in an atmosphere where there are less estrogen levels, the receptivity is better. But in poor responders, we do not have, she is already having less number of follicles, the estrogen levels are not going beyond 1200 or 1500, so there is no compromise in endometrium receptivity. So it has seen that all the outcomes are, they are not significantly different if you compare fresh transfer versus frozen embryo transfer. So there is no need of thinking of fresh frozen embryo transfer in poor responder. What about now, let's go to, after we have learned about expected poor responder, which is group 4, let us understand about Poseidon class 3 poor responder, which is again expected poor responder but less than 35, so young patient. I think that always keep it in mind, look at that age. If a patient is young but having just antral follicular count of 3 or 4, but push her to go for her own stimulation, because she is the one who is going to give you quite surely a better embryo and a better pregnancy rate. So significantly lower rates of clinical pregnancy, live birth and singleton live birth rate among young patients with diminished ovarian reserve. I know that if we compare the same age group patient with the normal responders, they are going to do poor. But if you compare them, there is a better pregnancy rate, lesser miscarriage rate in these young patients because of the young, their chances of having better oocyte is definitely more in comparison with the patient who is more than 35 years old. If you look at the cumulative live birth rate, below 35 it is 22, 18, 17. After 38 it is going very significantly down. So do not discourage your young patient who are less than 35, even if they are going to give you 2 or 3 oocytes, push them to undergo IVF because they will still do well, and their cumulative pregnancy rate is going to be much better. What about unexpected poor responder? Now unexpected is what? They are having good reserve. I have started stimulation. They are supposed to give me a good response because their reserve is good, but they have responded poorly. So there is something wrong in them, and these are the problems. Many times there is a single nucleotide polymorphism in the receptor or genes of gonadotropins. There is commonly they have been associated with FSH receptors polymorphism and also the LH receptor polymorphism. Sometimes it is iatrogenic. You have started only low dose. Suppose you have started only 225 of HMG, they are going to respond low. Okay, so we have to judge with antral follicular count and then decide the dose. So even low gonadotropin starting dose is the reason for such kind of patients. And same patient, when you start a higher dose, they respond much better. Asynchronous follicular development is one of the way of interpreting same young patients with adequate reserve. So they do well with that GnRH day 21 protocol which we discussed. And technical issues related to final oocyte maturation trigger and oocyte retrieval. So like obese patient, again, they do not show a oocyte maturity with your SCG trigger, and they do perform. Now what to be done for such patients? One of the very important strategy I always feel for such patient is to go for a GnRH agonist day 21 protocol. They will do much better with this if they have a asynchronous growth. Second, use of recombinant FSH in preference over urinary gonadotropins preparation is the first choice for such Poseidon group 1 and 2. FSH doses increase, so you keep on increasing doses. So you have started, say for example 300 dose, after 5 days you increase it to 350, after 2 days, 7th day you increase it to 400. So you are pushing those smaller follicles to come into the cohort. So FSH increasing doses is a good strategy for such patients. And of course, as I discussed in the previous slide, that such patients who are group 1 add recombinant LH if they are responding poorly to your recombinant FSH, and they will do, instead of cancelling that cycle, will do much better. A meta-analysis of efficacy of progesterone prime ovarian stimulation with medroxyprogesterone. So instead of agonist protocol or antagonist protocol, can you use medroxyprogesterone for such patients? So they say that the metabolites of medroxyprogesterone acetate that include androgens, which may help promote the proliferation of granulosa cells in these group of patients. So they stimulate the growth, they develop the follicle, and thus they improve. So progesterone priming is probably definitely helping these kind of patients. They may give you a better follicular growth. But we know that with progesterone prime downregulation, we cannot do a fresh transfer. Though poor responder, we always wanted to do a fresh transfer. So in those proven patients having a bad oocyte quality, you can use a progesterone prime ovarian stimulation and go for frozen embryo transfer. Now these are just to summarize strategies: pre-treatment with androgens, pre-treatment with estrogen in the late luteal phase, don't do natural cycle, starting dose should be 300 IU of recombinant FSH or 450 IU of recombinant HMG. Step-up protocol, do not give extra oocytes, especially for poor reserve patients. GnRH agonist and GnRH antagonist have a comparable results in this patient. Freeze-all strategy compared with fresh ET has no impact on poor reserve patients. And pulling strategy also has got no beneficial effect, so do not practice. So success comes from knowing that you did your best to become the best that you are actually capable of becoming. So learn the strategies according to the literature, practice them, because only once you practice, you are going to gain that confidence of using that strategy for that patient. So thank you for patient hearing. Thank you very much. Any questions if you have, we can take it. Otherwise, we can proceed for Dr. Charulata's talk.
Thank you, sir.
Thank you.
Let's move toward the next talk on imaging modalities for breast disorder. I invite Dr. Charulata Bape ma'am. She is a consultant at Dinanath Mangeshkar Hospital. She is a young, dynamic and won young entrepreneur woman award recently. Over to you, ma'am.
Thank you so much for that kind introduction. And after those blazing talks on poor responders, on AUB in adolescents, and recurrent pregnancy loss, we come to this completely different topic. Of imaging in breast diseases. So once again, it's a pleasure to meet old friends, and so Dr. Kiran Sarda, member of our breast committee. Thank you so much for being here, and I'm sure that Solapur OBGYN Society will also go ahead and move ahead in improving breast awareness and spreading the message of early diagnosis of breast cancer. Monica, always a pleasure meeting you. You are an asset to your society and to FOGSI. So indeed, happy to meet you here. असं नका करू काही पडणार नाही. So friends, let us start with a show of hands. How many of us here have a family member, a relative, a friend, a colleague who has suffered from breast cancer? Quite a few of us, I think, right? Breast cancer has already overtaken cervical cancer as the leading cause of cancer in urban Indian women. 1 out of every 28 females in India will develop breast cancer during their lifetime. In India, the average age of high-risk group is younger as compared to the West. I think this is a very important point for us to remember that in the West, the incidence of CA breast is rather high between the age of 53 to 57 years. But in our country, we see younger girls between the age of 43 to 46. And, I had a girl who was the youngest, which was 28 years of age. Probably somebody in the audience might have seen even younger girls. So the whole point is that breast cancer is occurring at a very young age in our country. We all need to realize that we have to be aware of the breast screening methods and the imaging methods, and hence this talk. Well, in the West, most cancers are detected at stage 1 and early stage 2, while in our country, it is detected at stage 2B and beyond. This translates into more radical surgical procedures, more toxic adjuvant therapies, and unfortunately, more deaths. The 5-year survival rate is 56% among patients diagnosed with breast cancer at a later stage as compared to 85% for cases diagnosed early. And hence, friends, the need to screen the breast. So what are the objectives of today's talk? To identify the various imaging modalities for screening of the breast and for diagnosis of various breast diseases, essentially breast cancer. Help in the early diagnosis of breast cancer, which is considered vital for a longevity of our patients. Compare and contrast the various modalities as far as efficacy and cost is considered. Have a consensus on which modality to use when, and decide an imaging protocol which is best suited for your patient. It has to be tailor-made for that particular patient. Who sees the human face correctly? The photographer, the mirror, or the painter? Asked Pablo Picasso. And friends, we need to ask ourselves, who sees the breast correctly? Ultrasound, mammography, MRI, or a combination of our knowledge, our clinical practices, and all these imaging techniques. So let us start with the basics about the breast. The breast is divided into 15 to 20 lobes by septae. Each lobe consists of fibrofatty tissue and glandular tissue. A lactiferous duct which is lined by cubical epithelium is going to drain a single lobule, and each duct is going to divide and subdivide and ultimately end in the alveoli, which is lined by a single layer of milk secreting epithelial cells. There is a rich capillary network, and myoepithelial cells are going to surround these alveoli. No talk on the breast can ever start or ever end without talk on the triple assessment algorithm. A good and thorough clinical assessment, imaging modalities, and a tissue diagnosis has protocolized the management of any breast problem. And so all of us need to have this one take-home message, that these are the 3 fundamental things whenever we are thinking about a breast problem. So what are imaging modalities? Well, a type of medical imaging technique which utilizes a certain physical mechanism to detect patient internal signals which reflect either anatomical structures or physiological events. You can use different forms of energy for imaging modalities, and these are going to help us in the diagnosis, in the treatment plan, and the response to treatment. What do we have as far as the breast is concerned? You have the ultrasound, which is routinely available everywhere, the mammography, thermography, which is a new and probably an evolving technique, the MRI, once again, which is quite time tested, and electrical impedance techniques, nuclear medicine techniques do exist. So let us see when we are going to use what. Now, whenever we say breast, the first thing that comes in our mind is, of course, a mammography. So once again, let us have a show of hands, my dear friends, as to how many in this audience has done their own mammography. So once again, it is the duty of our breast committee that whenever we go, I think this time we had a little hurry, we couldn't, discuss this point much, but whenever I go for any CME anywhere, we at least plan it 1 month in advance, and we make sure that all our gynec friends are the first ones to undergo their own mammography so that they realize the value of it, and so they themselves can realize that no, it's not such a painful process, no, it hardly involves any radiation, and so they will be in a better position to encourage their patients. So, young ladies and dear friends, the second message probably today is that we are all going to go back home and make sure we do our own mammography. And why do we want to do this mammography? Because it is a routinely used screening and diagnostic procedure. For the menstruating women, it has to be done post-menstrually. Otherwise, it can be done any time in those who are who are menstruating. It has to be done post-menstrually. For the menopausal women, it can be done any time. It is the standard of care for a clinical abnormality. If you have a suspicious thickening, the woman is complaining of some kind of strange pain, you can palpate a mass, there is a persistent inflammatory finding, there are some skin changes, and of course, whenever there's a lump in anybody found beyond 30 years of age, you always do a bilateral mammography. You never do only one breast mammography. At least 2 views and additional views, if needed, have to be taken. Friends, it is the man behind the machine who's most important. So please make sure that you send your patient to a good mammography center with a good machine. The Byers classification is something that we all need to know about. Yes, mammography does have its share of false positives. Radiation can occur. These are a few of the drawbacks which do exist. But what we need to realize that currently mammography is the gold standard method to detect early stage breast cancer even before the lesion becomes clinically palpable. So friends, your patient can say, "But doctor, तुम्हाला तर हाताला काही लागलं नाहीये, तर तुम्ही का पाठवता मला? मला नाही आवडत ते machine बिशीन नको, मला भीती वाटते." What you need to let her know is that your mammography is going to tell you about even smaller lesions which are not clinically palpable, and so you're going to have such a early diagnosis of this dreaded problem. Cancerous masses and calcium deposits tend to appear brighter on the mammogram. This method is very good to detect ductal carcinoma in situ. So friends, it is an in situ carcinoma. You're not going to be able to palpate it, and mammography is what is going to diagnose it. Okay? It has helped to decrease the mortality rate by 25 to 30% in screened women when compared with the control group after 5 to 7 years. Randomized trials of mammographic screening have provided strong evidence that early diagnosis and treatment of breast cancer reduces breast cancer mortality. I think, friends, it goes without saying, early diagnosis saves lives, and not only lives but the breast as well, because we all know that we can move on to oncoplastic procedures wherein you have a quadrantectomy or just a lumpectomy along with neoadjuvant chemotherapy, which can preserve her self-esteem, her femininity, and the breast, of course. You have a number of types of mammographies which are available. The conventional mammography, previously we used to have those X-rays. I'm sure all of us remember them. Of course, today we have digital mammography everywhere, and of course we need to use that, okay? So when you do a screening mammography, that means, what do you mean by a screening mammography and what do you mean by diagnostic mammography? Screening is when the woman has no problem, but we are doing it as a routine screening test, as we do a routine pap smear, okay? So here 2 views are required, the mediolateral oblique and the craniocaudal view. While in a diagnostic mammography, like if you're palpating a lump, if she has abnormal nipple discharge, she has some complaints related to the breast, then you may involve more views, a spot compression, a magnification may be required. Now there is something called as the digital tomosynthesis mammography. This is like a CT of the breast, okay? So there is very minimum compression involved over here. It is fantastic. It gives you multiple images. You can see the breast in a 3-dimensional manner, and I think it is one of the best methods for diagnosis, early diagnosis of breast cancer or any lesion in the breast. Of course, it is slightly expensive. I don't know whether Solapur has this 3D mammography or 3D digital tomosynthesis mammography, but in Pune we do have good centers which do this, and indeed our patients do benefit a lot. Now there is a variation called as ductography. Suppose you have a patient of abnormal nipple discharge, then we have to make sure to find and look inside the duct. And for this, ductography is like, you have a dye which is injected into that particular duct after cannulating the duct, and then you take the mammography to find out whether there is a papilloma or a DCIS, that is a ductal carcinoma in situ in this particular case. Now there's a recent development like contrast enhanced digital mammography, which is using an IV injection of an iodinated contrast agent. We know about, your MRIs with contrast, something similar to that. And they found that there's an increase in sensitivity from 0.43 to 0.62, and they also observed a better sensitivity in the case of dense tissues. Now friends, dense breasts are a big problem to radiology, the radiologists, because we'll just talk about it a little later on, because it is very difficult to visualize a lump in dense breasts. I think this is a very, very important slide for all of us. We need to know what are the guidelines for screening. The American the American Cancer Society guidelines say that between the age of 40 to 44 years, you have an option to begin annual screening. But in our country, where we just talked about breast cancer being present even in younger age groups, I think it is must that we start breast screening with mammo at this particular age. Age 45 to 54, annual screening has been suggested, and 55 years and older, the screening every 2 years is recommended. Of course, there's an option to screen annually. You're going to discontinue screening when life expectancy is less than 10 years of age. Now, this is the screening guidelines for a normal lady who is not high risk for breast cancer. If she's high risk for breast cancer, there are different guidelines, and these will not hold true for that. I think the BIRADS, the breast imaging and reporting and data system, is something that we all need to at least know about, okay? Because we have to be able to analyze it, we need to interpret it, our brain is, whatever our mind knows, only that the eye can see. So suppose you get a BIRADS 0, आपल्याला वाटतं की अरे कमी स्कोर आहे काहीच प्रॉब्लेम नाही. No, that's not what it means. It means that additional imaging or prior examinations are required. That means you have to recall the patient for additional imaging. BIRADS 1 means it is a negative mammo, there is no problem with the breast, and you can stick to a routine screening. BIRADS 2, it means it's benign, okay? Once again, you may see a small cyst, you may see a small area of fibrocystic disease, you may see just a tiny fibroadenoma, you may just see a few calcifications here and there. So a routine screening is mandated over here. Now the problem is BIRADS 3, which says probably benign, okay? This is where all the confusion starts. That means you have to have a short interval follow-up for her, and rather than doing a yearly mammo as has been suggested, she requires a 6-monthly mammo, okay? There is a slight likelihood of cancer in this particular patient. BIRADS 4 is suspicious, our antennae are going to go up, you need a tissue diagnosis undoubtedly. Again, there are the 4A, 4B and 4C are the sub headings out here. BIRADS 5 means it's highly suggestive of malignancy, tissue diagnosis again is required, and here you have a 95% likelihood of malignancy. And BIRADS 6 means that she's already had a biopsy, she's proven case of CA breast, and you're just imaging her for probably further treatment. Now there is one more kind of a staging of the breast which is done depending upon the density of the breast, okay? So there are mammograms here, you can see that when there is more of glandular tissue or more of connective tissue, more of supportive tissue, the breast is going to become a very, very dense breast, and here it becomes very difficult for a mammogram to find any kind of lump, and these are the cases wherein you might have to go in for an MRI, okay, because a mammogram cannot find a lump in these cases. So we were just talking about the 4 categories of breast density which may be reported. So the one, I think it is A, B, C and D. A is just fatty, B is scattered fibroglandular density, C is heterogeneously dense, and D is extremely dense. Friends, we must realize that for some reason, extremely dense breasts and breasts which show calcification on mammography have been found to be very high risk for breast cancer. So whenever you see a mammography showing dense breasts or showing calcification, please make sure that you resort to some other methods also. Now coming to ultrasound. Such an easily available, accurate tool that we all have. I'm sure most of us in the audience have an ultrasound machine. Am I right? How many of us have an ultrasound machine in our... Yes, many of us. So how many of us have touched that small probe which is used for small parts and kept it on the breast? Fantastic. Okay. So I think just like we learned TVS, बघून बघूनच शिकलो, कोणी आपल्याला हात धरून शिकवलं. Okay, here also we just start using that particular probe, just place on the breast, just see how a normal breast looks like. When you do 5, 10, 50, 100, slowly you will, I'm not even saying that we are going to replace the radiologist, but let us get a hang as to how the breast tissue looks. Let us enhance our own knowledge about the whole thing, and slowly you will be starting doing, small cyst aspirations. You maybe even start doing small tissue biopsies for a fibroadenoma which is superficial under ultrasound guidance. So previously ultrasound was used only to distinguish between lumps and cysts, but today its use is widespread. I'm sure that you all must have realized that whenever you send a patient for mammography, almost all of them will have an ultrasound done along with it. That is at least the trend in Pune, and I'm sure in Solapur also they must be doing the same thing, because we know that both of these imaging modalities are complementary to one another. Okay. So today it is used in a very big way for local pre-op staging. It detects multicentricity, it tells you about the lymph nodes, guided biopsies, aspirations are possible. And friends, very, very important to remember that it is the best imaging modality in the younger age group and for women with dense breasts. Pregnancy and lactating mothers, it is very good because it does not release any radiations, and so these are definite indications where an ultrasound is going to score over mammography. Continuous real-time imaging can be captured, and as we said, it's an adjunct to mammography in the assessment of both palpable and impalpable breast abnormalities. But what about using only ultrasound for screening? Okay, we said that mammography is the best tool for screening for breast cancer. But then why not ultrasound? It is so much easily available, there's hardly any pressure and things like that, but it has been seen that ultrasound screening in asymptomatic women can cause unacceptable false positive and false negative outcomes, and so we cannot use it as the only single modality for breast screening. But once again, just as they say that self-breast examination has not been shown to found to decrease the incidence of mortality from breast cancer, but still we advocated in India so that our women become breast aware. Similarly, in a place where you do not have mammo or do not have MRI, or she has to travel a lot, we say that use the ultrasound at least, do a sonomammography and have a small screening done. And for younger age patients, obviously we would like to err for an ultrasound before the mammogram. The diagnostic yield of mammography with an automated whole breast ultrasound for women with dense breasts and or at an elevated risk of breast cancer is said to be better. And advancements in ultrasound, you have now elastography, which is combined with ultrasound, wherein you find out what is the elastic nature of the tissue. The normal breast is going to be more elastic, a lump or a hard lump is going to be less elastic, and all these things are added. So you can use the Doppler ultrasound, the sonoelastography, and all these are going to help in better diagnosis. Okay, so many studies have been done, and this J-START study, the cancer detection rate was 3.3 per 1000 screens in the mammo arm and 3.9 per 1000 screens in the mammography plus ultrasonography arm. So everybody says that whenever you have a combination of ultrasound along with the mammography, it is found to be the perfect screening method. Again here, I'm sorry, those red lines are a little funny. The detectability of breast cancer by ultrasound 96.5 or full field digital mammography plus computer aided detection plus ultrasound is 100%. So if you have a full field digital mammography, which is the 3D mammography, is going to be the best. If that is not possible, a digital mammography plus an ultrasound will go a long way in early diagnosis of breast cancer. All our studies are saying the same thing. So what we have to remember is that we have to look for the benign characteristics. Like when you see that it is well circumscribed, if it is hyperechoic, it is 100% diagnostic of benign. If it is more wider than deep, you must have realized that fibroadenomas are more wider than deep. That also has a very predictive value of it being benign. Very gentle curves, smooth lobulations, thin echogenic pseudocapsules, all these indicate that it is mostly a benign problem. So coming to simple cysts, this is how they look, okay? So clearly it is benign, it is well circumscribed, it is round or oval, it is anoic, echoic, and there is posterior enhancement. This is a Biarritz 2, means which is a 100% benign thing. And so friends, all of us need to start doing this. Is not my video, it is taken from the internet, but I think we all need to realize that we can start doing aspirations of these simple cysts under ultrasound guidance. We all know that in patients of fibrocystic disease, they complain of pain. So very often there are these kind of cysts also which are present, and it is so easy, that you just stabilize that cyst under ultrasound with your assistant's fingers. You have this very fine, you just take a simple 18 gauge needle also, attach a 10 cc syringe to it, and under ultrasound guidance just insert your needle into it and aspirate it. You can send the fluid for cytology. We are almost 100% sure that it's going to be benign, but the patient is going to thank you so much because you are her trusted doctor, you are her obstetrician. She feels so much more comfortable with you, and you've done it in a jiffy. She's just come to OPD, you palpated it, you feel it is a cystic, you place the ultrasound probe over it, you say, hey, it's just a simple cyst. Are you okay if I remove it? You may give a little bit of local after cleaning it with a swab, put in your 18 gauge needle, and it's done. The patient is going to thank you forever because, she's going to be relieved of her pain completely. Now these fibroadenomas, again a very, very common problem. You have young girls coming to you, the reproductive age patients coming to you, and here we do see that these are uniformly hypoechoic, which are more transverse than vertical, and the preferred modality for diagnosis over here is the ultrasound. Even if clinically you can feel it's an ultrasound, please make sure that you do a sonography or some imaging technique for this particular patient, because friends, this 28-year-old girl which I talked about, she had just a 1 centimeter lump. We sent it to a very good sonography center, and they did not say it's a fibroadenoma. They said that please do some further imaging. We did ultrasound guided biopsy at a good center, and it turned out to be malignant. Of course, she had a very strong family history wherein her maushi and her aji both had breast cancer. But just imagine that such young girls also can come with so as we say, any newly palpable mass, you cannot label as benign unless all the imaging criteria are met with, okay? Anything other than benign criteria must be either biopsy depending on the age and followed up. HP is to be obtained prior to excision. This is very, very important. So we have to do the imaging modality first and then take the biopsy, because if you take a biopsy first and then send her for imaging, it's going to get distorted because of the inflammatory process. So it has to be clinical examination, then the imaging followed by the biopsy. So just these are a few images as to how the fibroadenoma looks on ultrasound, how it looks on mammography. Again, fibrocystic disease is so common, okay? It has cystic lobular hyperplasia and fibrocystic, and it has so many components. She comes to you with pain all the while, you feel lumpy breasts, you don't know what exactly is happening. Always remember, please do mammography in these patients without fail, because although it is not associated with an increased risk of malignancy, some certain histopathological types do have a 50% chance of developing CA breast, okay? So just imagine, these are the fibrocystic disease which appears so dense, and it can be really scary when we see it, but our good radiologist friends are going to diagnose it properly, and that should be quite fine. If the patient is, it is always a good idea, if you want, just do a core needle biopsy. So an FNAC is rather out. None of us do FNACs for breast lesions any longer. A core needle biopsy is what we always advocate, and probably in some next talk we'll be talking about core needle biopsies. This is how once again they appear on mammographies. And so it is a very long thin needle, very simple to do core biopsies. Again, these can be done under ultrasound guidance. You can see that fine probe which has gone inside. You have to take the biopsy from 3 or 4 sites, and this is another advantage of the ultrasound, where you can take guided biopsies. Early CA breast, very tiny lesions can be caught by a good mammography image of CA breast. So we talked about ultrasound, we talked about mammography, and now we're talking about thermography. So what is thermography? We know that cancerous and precancerous tissues have a higher metabolic rate, resulting in growth of new blood vessels. This causes a higher temperature in the abnormal or the cancerous breast tissue as compared to the normal tissue. And so thermography provides a functional information on thermal and vascular conditions of the tissue rather than structural characteristic like any other breast cancer detecting techniques. So it is a promising screening tool, but once upon a time, it was the radiologist or the breast surgeon who used to analyze these thermography images. But today we have artificial intelligence enabled thermography machines. Maybe there may be some in Solapur also. So wherein it's a non-touch technique completely. They just cool the breasts first. They make sure that the girl does not have fever, and they just capture images, and it is artificial intelligence which is going to analyze these thermography images and tell us if she requires any further screening or not. But if you talk to any breast surgeon, or if you talk to any radiologist, they say that they do not believe in this particular modality at all. Now coming to MRI. Very good resolution allows simultaneous evaluation of both the breast. It is used as a screening test along with mammography. Again, we have to talk about screening and diagnostic. So where do we use it as a screening test? We use it along with mammography in women who have the BRCA mutation or those who are at a very high risk of breast cancer. It also helps to evaluate cases of inverted nipple where you cannot find anything else. It is the problem solving investigation. That means it is the diagnostic person. You have a big problem as to how to treat a poor responder, you go to Kundan Ingre sir, is it not? So he is the problem solving person. So when nobody knows anything, then MRI is going to help you to sort out the case. It will help you to decide if lumpectomy or mastectomy is the line of management. In axillary node malignancy with an unknown primary site, you have to do an MRI. Of course, to assess the further line of management or after surgery, staging the disease, finding multicentric disease. Okay, it has a very high sensitivity, friends, but it has a low specificity. This is very important to remember. So, if you find something on MRI, it doesn't, I also sometimes get confused. What is the problem area of MRI? It is not routinely performed because of high cost and limited availability. It does not show microcalcifications, not good at diagnosing ductal carcinoma and C2, may lead to false positives, takes nearly 1 hour, and it may be used even in benign breast disease for those at high risk of malignancy. CT mammography, optical imaging, these are few other techniques which are available, but neither have I used them nor have I seen them anywhere in my city. And a hybrid technique combining PET and CT is useful for staging potential metastatic cancers. All of us know about the PET scans and the CT scans, and this technique has the combined advantage of both CT and PT. Tumor location is better captured by CT and PT. It indicates a metabolically active or malignant tumor based on the glucose uptake. So in PET, we know it's a nuclear medicine imaging technique. Malignant tumors are characterized by increased glucose metabolism compared with normal cells. This produces a good contrast between cancerous and normal cells in PET images. So MRI and PET are complementary and valuable in monitoring response and assessing residual disease of locally advanced breast cancer treated with neoadjuvant chemotherapy. Again, it is expensive and yields poor resolution images. The patient is going to be subjected to radiation exposure, but whenever you will want to look for distant metastasis, this is what we are going to do. So friends, once again, a point about screening for breast cancer. Please, you have to guide your young college-going students also about self-breast examination. And that is what, again, the breast committee has taken upon itself, that we are holding many, programs, social programs, many camps in schools and colleges, so as to make our young girls breast aware, teach them about self-breast examination. So here, although we have written it is optional to teach them self-breast examination, I think it has to be taught to each and everybody. Breast clinical examination in young girls every 3 years. Age 40 and above, mammography every yearly, and even a clinical breast examination every yearly. In high-risk patients, mammography plus MRI has to be done annually. So, now let us see if everybody is awake or asleep during this particular program. And we have a small rapid-fire questions. A young 35-year-old girl with breast implants and a history of CA breast in her family. What screening technique will we use? It has to be a mammo or an MRI, okay? You have an implant also over there, okay? And she is high risk for breast cancer, you have to have the MRI also. 45-year-old wishes to do routine breast screening. Mammo, fantastic. And maybe we'll all do an ultrasound also along with it. 52-year-old with abnormal nipple discharge with no palpable lump. Mammo karuya? Just now only we said, no, even if no palpable lump, mammo might find something good. So I think we should go ahead with a mammography and ultrasound, and we just talked about ductography also. So later on, we may need to do a ductography. And if the mammography and ultrasound are inconclusive, then yes, we go ahead with the MRI. 55-year-old with a large fungating mass over the right breast. Perfect. Okay. We can directly do a biopsy. And of course, you may, all this mammo and all will be too painful because she has a large fungating mass and it is just right there. Of course, to find out about multicentricity or some other growth elsewhere, to look at the axillae, we may need to do a mammo, and maybe a PET scan also for metastasis. But with such a large fungating growth, it is a biopsy. BRCA positive 30-year-old wishes to do breast screen, wants to know how she has to screen her breasts. MRI for a BRCA positive, okay. She has definitely a very high incidence and we would definitely advise that she does an MRI. So in conclusion, friends, mammography is the screening modality of choice for detection of breast cancer. If possible, all women should avail the benefit of a 3D mammogram. Ultrasound is the modality of choice in young women or in pregnant and lactating women. Always keep a high level of suspicion of pregnancy-associated breast cancer. We didn't touch upon this, but there have been cases wherein, she's just delivered and she comes to you with a painful breast. We all think it is mastitis. We all give her antibiotics, okay? First you give her Augmentin, then you give her simple mox, then you give her something else. And so much time is lost in all this, and it is actually nothing other than pregnancy-associated breast cancer, which is a very fulminant and high-grade malignant condition. So we have to be aware of this condition. MRI imaging is to be used for a specific subset. Biarritz assessment criteria should be assigned and acted upon. Palpable breast lumps that do not fulfill all benign imaging criteria should be biopsied. Biopsy correlation is mandatory for all suspicious lesions. No additional imaging should obviate a biopsy. Friends, I come from the city of Pune and our presidential candidate for the upcoming FOGSI election is Dr. Sunita Tandulwadkar. She is very much from your city and we request you to kindly support her presidential candidature. Thank you so much for a patient hearing. Thank you. Any questions we would?
Thank you, ma'am, for the wonderful talk. I request Dr. Anjali Jamma, ma'am, to felicitate Charulata, ma'am. Now I request Dr. Diwakar Thippe for FOGSI awareness on Manyata talk.
Good afternoon, everyone. So firstly, thank you Dr. Anjali ma'am and the organizers for providing us this platform to talk about FOGSI's own quality movement called Manyata. So Manyata is a quality improvement certification program of FOGSI. So Manyata is a quality improvement certification program of FOGSI, which was launched in 2017 when Dr. Reshma Pai was the president. So we all know the challenges and the need of quality in the private sector in India. So why do we need Manyata? So for safe, effective, accessible, patient-centered, timely, efficient and equitable care. So though we have Manyata in rest of the states, the program is called as Lakshya Manyata in Maharashtra, as it is a collaboration between FOGSI and Government of Maharashtra. So this was launched in 2019 when by Mr. Eknath Shinde, who then was the health minister. So this is how the Manyata journey is. So once the facility registers for Manyata, they have to fill the registration form, they have to sign the letter of intent. When that is done, we'll do the baseline assessment of the hospital for the labor room and operation theatre to understand the baseline scores. Once that is done, we'll start with the quality improvement journey. So we'll do some online training sessions, some on-site training sessions, so that will be the hybrid training modules. Once the trainings are done and the facility is ready for assessment, we'll recommend the FOGSI for the assessment. So there will be two assessments happening for Lakshya Manyata. So Manyata will be assessed by the FOGSI assessor, wherein Lakshya will be assessed by the Government of Maharashtra assessor. And once both the assessments are done and they are qualified, the facility will be rewarded with the Lakshya Manyata joint certification. So the difference between Manyata and Lakshya Manyata is Manyata only has 16 clinical standards, whereas Lakshya Manyata has 16 clinical plus 10 facility standards. So this is how the division of 16 standard is. So we have one antenatal standard, 13 intrapartum, one postpartum care standard, and one C-section standards. So this is the overview of 16 standards. So it starts with ANC, then talks about readiness of labor room, then assessment of pregnant women, to filling partograph, to management of complications like PPH, eclampsia, and newborn resuscitation, kangaroo mother care, and infection prevention protocols. And these are the 10 additional facility standards in the Lakshya Manyata program. So that focuses on infrastructure improvement, standard operating procedures, and the documentation part. So this is the overall data that we have under the Manyata program. So we have more than 1800 plus hospitals registered and certified for Lakshya Manyata. And in Maharashtra, we have more than 250 hospitals certified for Lakshya Manyata. So the trainings are being done by the FOGSI recognized Center for Skill Enhancements called training centers. So we have one in Pune, one in Navi Mumbai. So as we have in Rajasthan, UP, and other parts of the country. So this is the overview of 1800 plus registrations that we have till date, and we have more than 20 registrations from Solapur city itself. So is it effective? So as I said, we have more than 20 hospitals from Solapur, and one of the hospitals that is certified is Unique Hospital run by Dr. Ajit Gandhi sir. Sir, if you can please share your experience towards this Manyata journey, how it has helped, to improve the quality of your center. Yes.
So you want mic?
Thanks. Mine hospital is the first privileged hospital to have this Manyata recognition in our district, as all of you know. And I would be sharing you some benefits and experience which we had with this Manyata certification. All of us must have gone through the situations in our career, like we are in a movie and then we get a call from the hospital that baby is not crying, and then you know what happens. Or something like you are held up in a bathroom with shaving, and then suddenly your staff calls you that patient is bleeding like anything, and what should I do? So these are the obstetric emergency situations where we need to have a competent, skilled, and knowledgeable staff to manage all these situations. We can't be in our labor room 24 hours a day and manage those things. So we have to have our competent infrastructure. And I think this is one good solution for all this. We have gone through all this process, and they do carry out a very good training course which improves the competency of our staff. The Lakshya part, the standards, there are so many standards now which are expected by the government, by the insurance companies, and even the public at large. Like the fire standards, the documentation standards, the medication standards. So many things are expected by the society, by the government, by the insurance companies. And this is one opportunity where we get to improve our standards and our skills. And the benefit is we have a peaceful sleep. So I recommend all of you to go for a Lakshya Manyata certification program. That's a good program. You try it. I am happy with it. I am reaping the benefit of all this. I suggest all of you to do the same. Thank you.
Thank you, sir. I request Dr. Anjali Jamma ma'am to felicitate Dr. Divakar. Last but most awaited topic of the today's CME is a panel discussion on case-based discussion on infertility. I request our moderator for today's panel, Dr. Vijay Pawar sir and Dr. Bahubali Doshi sir. Dr. Vijay Pawar is a young brigade of SOGS, and what about Dr. Bahubali Doshi? He is the young person of our society, I think the youngest one. And the panelists for today's discussion are Dr. Kundan Ingle, Dr. Minal Chidgupkar, Dr. Rajesh Darde sir, Dr. Revti Rane, Dr. Hasina Sheikh and Dr. Supriya Birazdar. Dr. Revti Rane madam, she is a director at Apex Multispeciality Hospital, Akluz, director at Akluz Fertility and Test Tube Baby Center. Her special interest in high-risk pregnancy and internal iliac ligation. Dr. Hasina Sheikh, she is a director at Sims Fertility Center and Wellness Nursing Home, Solapur. Dr. Supriya Birazdar, she is an infertility consultant at Navjeevan Fertility and IVF Center. Dr. Minal Chidgupkar, she is a director at Chidgupkar Hospital Private Limited. She is a senior infertility specialist at Apollo Fertility, Solapur.
Shall we start? I usually hate to conduct a panel because the panelists are sitting and we have to stand. Anyway, I'll start directly with the case. See, this is a 23-year-old couple, the patient married 1 year back, primary infertility, semen analysis normal, HSG tubes are patent, cycles are regular. She has been given clomiphene citrate 50 milligram for 5 days. On day 11, now I do a ultrasound and find that there is a follicle of 17 mm. Now, should I administer SCG?
So in this case, we have given a stimulation, that is the clomiphene citrate. Whenever you induce ovulation with clomiphene citrate or any letrozole, ideally you should give trigger with HCG. If it is a natural cycle, I may wait for the natural rupture of follicle, but whenever there is induction, I prefer to give HCG.
Anybody has any other
Anyone
opinion?
else?
We would like to know what is the endometrium at this stage.
Good.
One of the important point is to look at the endometrium. So what thickness you look for if you want to give a trigger. It's a clomiphene citrate cycle. So that is the trick over here.
For clomiphene-induced cycle, it is better to wait up to 18 to 19 millimeter, and the endometrium should be at least 7 millimeter. And we can, along with that, if we are confused about the size and the endometrium, we can always study the Doppler flow of the follicle and see what is the PSV, and then we can consider giving the trigger.
And recent studies have shown that in the CC or letrozole cycle, most of the time it is monofollicular, and that ALS surge, natural ALS surge has better pregnancy rate compared to the HCG. So we can wait for the natural surge.
So will you call her again and find out whether it has spontaneously ruptured?
So in the panelist, I think a lot of controversies. The sir wants to give HCG, madam wants to wait till 20, and Dr. Hasina wants to not to give HCG and wait for the natural rupture. So
well, will you go for some additional information about the follicle? Anyone? Say any Doppler study, any one of you are doing it.
She just mentioned about the Doppler study and peak systolic velocity. We have to see how much amount of the blood flow, if it is more than 3/4 of that follicle is there, then we can think about the trigger. And also in clomiphene citrate, we can wait till like 1890 up to 21 also mm for the this administration of HCG.
Will you wait for, if you are going to do IUI on these patients, if you are opted to do an IUI, so will you give a trigger or you will wait?
It is better to give a trigger so that we would know the time of the, time of the.
So, sorry, go ahead.
So important point here to note is that it's a clomiphene citrate cycle. So there's a slight recent studies have shown that the follicle matures at around 20 to 22 millimeters and not at 17. So if it's a gonadotropin cycle, then 17 probably is the ideal, or maybe if you are going for a natural cycle. But generally for a clomiphene cycle, 20 to 22 mm is the size of the follicle. That is the recent literature that has said. The other thing Dr. Hasina has mentioned is regarding if the patient is ovulatory or anovulatory. So if the patient has got regular cycles, and if you are planning for a timed intercourse type of management for the patient, so it is better not to give the trigger. So that is also a gray area and quite debatable. Obviously for IUI we will go for a trigger so that we can better time the IUI.
Just one more question. I mean, I have recently heard saw the video by Anil Gudi. Yeah. Now, his very small video, the question was, if the patient is cycling regularly, is there any benefit of giving ovulogens?
So I think it's a case of unexplained infertility, as we can see, because the cycles are regular, analysis normal and HSG. So it is recommended if the patient is infertile, that is she has tried already 1 year, minimum 1 year, and she is less than 35 years. So it is suggested to induce with ovulogens than doing a expectant management. Okay. So that's what is the ASRM guidelines also. Fine. Recent 2019. Yeah.
Now this is a 25-year-old patient. The BMI is 32. She is married for 5 years. Primary infertility. Bleeds only on withdrawal. Ultrasound shows polycystic morphology. Semen analysis is normal. Now HSG, laparoscopy, drilling, no drilling, what are your choices?
Sir, first in this patient, 25 years old with BMI 32, I would ask that patient to reduce the weight that will help her in the further treatments and further ovulation in that patient, because BMI is more than 30. Then if I really want to choose between HSG and laparoscopy, as she is married for 5 years, I would not go for HSG, would go for laparoscopy, because it will give more clear view and more understanding about what is to be done, and if it is a primary infertility. Drilling and not drilling will depend upon her AMH and how much amount of AFC is present. Like if it is very high AMH, would definitely go for drilling, because that will help further in her ovulation and further if she goes in IVF. But if AMH is not that high, like less than 5, 6, I would definitely wait and not do drilling in that case. And choice of ovulation, recently that letrozole has given preference, because endometrial lining becomes less in CC, so letrozole. And adjuvant, there are many adjuvants.
So I would just like to say that she is with her BMI of 32, she is obese and she is polycystic morphology. So she is a case of PCOD. So she is bleeding only on withdrawal. I would like to differ here regarding straight away laparoscopy. Even if she is married for 5 years, we don't know when she has started the treatment and since when she is trying. So first line should be tubal patency routine. Drilling is, I wouldn't say it is decided only on AMH. We would definitely like to stimulate her, see whether she is responding to gonadotrophins, and if she is not responding to gonadotrophins or she is not affording and her AMH say cutoff more than 6, then only we would consider drilling, and if she is not willing to go for IVF, then otherwise drilling should be done in very selective cases, I would say, and rest of the things.
One point only, if she is married since 5 years but never undergone any treatment, my choice will not be laparoscopy, number one. Okay, then it is HSG. If she has undergone treatment, she has failed, she has never conceived in 3 or 4 induced cycles, then the role of laparoscopy is first, number one. Number two, no drilling at all. Nowhere in PCOS nowadays recommended no drilling. Okay, so there are much better treatments now where we can, we can concentrate on the ovulation induction protocols, down regulations parts, and we can achieve the similar results with ovulation induction cycles than doing drilling.
Very, very important point that Dr. Kundan has mentioned regarding drilling. So the take-home message has to be for all gynecologists: don't do drilling just because we know how to do it. Because a lot of cases come to us who are PCO diagnosed and they fall into the Poseidon 1 or 2 group later on because of Poseidon 3 and 4 because of low AMH and low FC because of drilling, and it becomes very difficult for us to explain them suddenly why the patient has become a poor responder. So this is a practical thing, no drilling at all. And anything anybody wants to add about adjuvants?
Metformin with letrozole will be shown a better ovulation. Other are controversial, like D-chiroinositol. So metformin I feel better. Even during IVF also, using 2 months of metformin prevent the or reduce the OHSS.
Along with that, if in the case of hyperandrogenic PCOS, we should consider giving DEXA steroids. That would definitely help her to give us a better quality oocytes and help her in stimulation.
I would like to use a combination like metformin and myoinositol combination. That also helps for the PCOS patients.
Say about this case. Now, the choice will first of all depend upon whether you are the first to treat. If she has been treated extensively, then again giving her clomiphene or letrozole will not work. Secondly, as everyone has agreed, that drilling is probably the last choice, only if the patient is non-affording for gonadotropins or not available for follow-ups regularly. If you are starting gonadotropins, then maybe you may have to repeatedly do E2 or call her, see for hyperstimulation or understimulation. So, and most important, first spend some time in lifestyle modification, probably spend more time in lifestyle modification, properly counsel the patient, ask her to reduce weight. Patients will always say, I don't eat much. Then you have to give many illustrations, convince her, and then only embark on the treatment. In the first consultation only you tell her that you are going to be here for at least 1 year. If you are lucky, maybe much earlier than that. But what happens is, the moment you prescribe something, the patient has that prescription already and she says, हे तर घेतलंच आहे मी, हे तर घेतलंच आहे. So you have to tell her, yes, maybe that you have to take it repeatedly. This is very important.
So one more point, because she's obese and BMI 32 and PCOS, that may mandate you to start metformin. But remember, always and always do GTT on such patient, because among this group, 30% patient will be actual diabetic, which we will miss it only with just starting metformin.
Very important is these are actually case of metabolic syndrome, which are presenting as polycystic ovarian syndrome. So it's
sir,
a lifestyle disease. We have to optimize the disease first. Yeah.
I wanted to ask you, sir, Kundan sir, I mean whether HbA1c, regarding GTT and HbA1c, because we were discussing in RPL also. So is HbA1c justified, or we should always go for GTT? I mean, even for RPL cases.
HbA1c cannot be a screening test for insulin resistance, point number one. It has to be GTT. 75 gram GTT and fasting and 2 hour value are the most important.
And fasting serum insulin has now, is not
We
have that in the next slide.
I have one question. If AMH level is more than 14, 16, still you will not go for drilling?
Now actually she is 32 years old. That is very, very important. So in as far as reproductive career is concerned, the most important factor for age and age. And what the cutoff that are given in the textbook is 35 years, right? For elderly. But we are in Indians it is 30. So always remember, whatever even Kundan sir had spoken about the poor ovarian reserve.
I think the whole purpose of drilling is to reduce chances or risk of ovarian hyperstimulation.
Right.
That is the only area where drilling has proven its role. Now we can avoid it with a simple stimulation protocols also, OHSS. So that is one thing which we should understand. So yes, AMH, as she rightly said, 14, 16, higher chances of OHSS. But drilling is not the first choice, even still there to prevent OHSS.
Yes.
Concentrate on the ovulation induction protocols.
Yeah.
But when we are doing laparoscopy, why not do it at the same time? When there is AMH,
She's got good point, but I think the literature is very clear that the risk which is associated with drilling is more than the benefits.
Yeah. So only patients category that what she is talking about will be those who are not going to afford for IVF.
Yeah.
So if
It
she
is
is
one
not
of the
going
good
for
procedure
IVF
for PCOS, but the risks are more.
and
Two
she is not
important points.
responding to the ovulations. So if she is not responding to ovulations, not affording to take gonadotropins, then maybe that is still a very, very less number of patients, but 99% I think ovarian drilling is out of the picture now.
Again, a 38-year-old, married 8 years, cycles are irregular, semen analysis normal, spill is there, the AFC is only 3.
Yeah, so it's a very interesting case. Lot of people getting married late now, and in our OPDs they come, and here it is 8 years. So all gynecs do get this type of patients, and we start with some treatment. So let's see what the panelists want to take
Her
on
clock
this.
is ticking.
Right, absolutely, yeah. So our clock is ticking 38 years. Again, look at the age. So first factor, always look at the age and then you plan the treatment. What exactly is required?
So her age is 38 and her AFC is 3. So she is Poseidon 4.
Right.
And we have very less amount of time in our hand. So it is better to counsel her to directly have a best possible chance with IVF. As a given, we have to give the best possible option. But if she is not affording, not willing, then we can try 1 or 2 cycles of IUI. That is my take.
Yeah. No IUI.
No.
No IUI.
Which is not affording
No
and
IUI.
not willing.
No IUI.
See, what has happened is for 8 years, probably in 8 years, even not because she is 38, she must have had a very low ovarian reserve right in the beginning. Now that we saw that it is 3, and all those 8 years of treatment has probably depleted her affordability. What I would say, all of us for that matter, you see, please ask one question. Am I going to do something different than what my other colleagues have done? And if you are not going to do something different than the others or better than others, please refer in time in the interest of the patient, not for the higher centers. In the interest of the patient, please. Don't hold on to the patient. Again, give clomiphene citrate. Do a folliculometry on day 11, 12. You will find the follicle, definitely. And when the patient comes to a IVF center or a higher center, and we say that this is that, invariably the history given is, हमारे डॉक्टर तो बोलते थे अच्छा था फॉलिकल तो होता है. So please, this is my request to all our colleagues that release them in time. I mean, not that the patient comes to me only. It can go to anyone, but don't hold on to the patient. Again, I get calls from many of our colleagues. Sir, follicle पण छान होतं आहे, तर मी 1-2 सायकल अजून क्लॉमिफेन देऊन बघू का? प्लीज. No. So, again, this has been, discussed now. So, age is the most important factor, determinant factor for fertility. Antral count is very low, AMH is low. So, maybe as said previously, you can give a couple of months DHEA by the time you prepare her for IVF. And now the dose, again, there is a controversy, but sometimes we start with 450 to 600 IU also, HMG. No trial and error again, no clomiphene, no letrozole or a combination.
But I think one important point for such patient in counseling is that never assure them that we will have a great chances of pregnancy in IVF. Number one, because it's only 3 antral follicles, plus she's 38 years old. So we may get oocytes, we may not get blastocyst, or we may not get pregnancy. So that point is very important that, and also at the same time, it is very important to counsel them that if you do not get embryo in the first cycle, that doesn't confirm that you will never get it again. That's also very important. It's completely their decision that 1 or 2 attempts they have to take, they will take it on the financial basis. But it has to be their decision, because we cannot say this, that she has never developed a follicle, so that means she should just go for donor oocyte. It should be just a second option, I believe.
So what sir had shown in his talk regarding the management of poor responders. So all the slides and presentations where he has mentioned about all these drugs that can be for optimization. The take home, if you see very closely to all the studies, we are interested in the pregnancy. We are not interested in how many oocytes they get, how many M2 you get, what is the fertilization, blastocyst. Ultimately, if you see the last line, the clinical pregnancy or the take home baby rate, it will be around 10, 15, 16%. Not in any study it is given more than 20%. So That too, you may require many cycles. So very, very important that these patients go fast to the IVF centers and start their treatment, because that the success rate of IVF is going to go drastically down after 35. But again, these all, again remember, the age for India is 30, not 35. That is what I have realized in the last few years of my practice in IVF. So for our age it is 30, not 35.
Sir, and I want to ask if we are stimulating with the higher dose, but after 7th, 8th day also, these low responders are not responding and not
Abandon
forming up
the
to
cycle.
fall.
Abandon.
You have to abandon the cycle.
I think sir had already mentioned in his
Yes,
talk.
you have to abandon the cycle.
But very important, we have to counsel patient, because it is ultimately पैशाचा game असतो आणि आपल्या इथे it is very difficult to counsel. पैसे परत मागतात. Difficult होतं ते सांगायला. And they expect 100% result.
If you, I mean, a day, if it comes in our life that you can give a guarantee to any infertility treatment, probably all of us will be the happiest persons in the world. All gynecologists. That day is not there. But at the same time, what I feel is, put it to the patient and never say never to the patient also. I mean, that also extreme should not be there. Don't do. Because I have seen, I refused a patient to undergo sterilization because her FSH was 85. And I said, why you want to spend money on tubal ligation, because you are not going to conceive. And after 1 year, she came with 5 months pregnancy. So, never say never, just say, I don't know, maybe if you are lucky, nashibat asel tar, but I don't have any other explanation, but put it to the patient. This is another case, 22-year-old girl, married 2 years, primary infertility, complaints of dysmenorrhea, right ovary is showing antral count of 7 and left ovary is showing an endometrium of 5.5 centimeters.
So how are you going to proceed? Anyone can.
Sir, I would like to give the ovulation induction and do ovulation induction timed intercourse first, because she is 22 years and 2 years of marriage. If not happening, with the IUI. But endometrioma 5.5 centimeters and not causing, and if there is a history of dysmenorrhea.
I would like to differ here. She is a young patient and she has dysmenorrhea. Her antral follicular count seems to be good and the size of the endometrium is 5.5. So I would like to do her AMH. And if her AMH is good, then considering her symptoms, we can make her undergo a laparoscopy, I mean a good laparoscopy procedure where the damage to the ovary is not done, and then we can, considering her age and the size, I would like to go for, I would like to go for IUI if she, we have to see the husband factor also, or we can try ovulation induction with time intercourse 1 or 2 cycles, but early and aggressive management should be done in such cases.
I think in this case, I would first like to know the history, whether she has taken any treatment in last 2 years. If they has undergone like many cycles of ovulation induction, then I might think of laparoscopy. Otherwise, if she has not taken, then I will prefer to induce the patient and not think of laparoscopy.
Okay. Suppose you do a laparoscopy. Suppose you decide to do a laparoscopy.
Ideally nowadays, previously we used to do like endometrioma, enucleation of the cyst wall we used to do. But because recently say they don't do the enucleation, just puncture, drain it out and start the patient on ovulation induction and let her conceive as early as possible. If you do the enucleation and this, there are more damage to the ovary and the ovarian reserve will reduce in their cases. So it's better to just drain and come out.
Yes.
Can I make one comment,
okay,
sir?
Please.
So, because it is a unilateral endometrioma, size also is 5.5, it's a bigger one. Now, as per the guidelines by Shri also, if she has a good reserve on the affected side, the antral follicular count is 6 or 7 on the endometrioma side, and AMH is more than 2 or 2.5, I think it's a good case to operate, because that is going to not only increase her chances of spontaneous conception, but it's also going to take care of her dysmenorrhea. So quality of life is going to improve. But suppose if in a different scenario, we have a unilateral endometrium of same size, but the contralateral ovary shows 3 or 4 antral follicles, and even the affected ovary shows lesser antral follicles, and AMH is below 1.5. I think my decision of doing laparoscopy here, I will restrict myself, because here first question is the fertility. So I'll first preserve her embryos, then can go for laparoscopy to take care of her dysmenorrhea. So approach will change according to her ovarian reserve status.
Will you first confirm that her tubes are patent, or because in a endometrioma there is some chance that her tubes may be affected?
I think that's what, those things are always going to be checked during laparoscopy, but the point of decision of doing a surgery for endometrioma will always and always depend on the reserve. What is there before surgery? If it is poor, less, I think we are going to reduce it further. So where we are going to put her into more tragedy. So in fact, preserve her fertility. Then because that dysmenorrhea is significant, where it is really affecting her quality of life, then that is also has to be given priority. So first preserve fertility, then take care of pain. So that should be the approach. So depending little individualization depending on the ovarian reserve and the severity of the symptom.
The next case is 26-year-old, married, 3 years, cycles regular, bilateral spill. The semen analysis is 10 million, 10% grade 4, non-smoker, non-alcoholic. His BMI is 34. He is obese.
Husband, here the husband factor, he is obese. So here first lifestyle modification has to be advised. Then considering his count 10 million and motility is only 10%. So I would like to get him investigated first. A blood report should be done. We have to rule out hypothyroidism, diabetes, and along with that, a good USG of the testicular Doppler can also be done to see what is the cause of the the count, and along with lifestyle modification and correcting other cofactors, and then we can go give an option of medical management and then proceed.
Okay. So what investigations will you do on him?
I think the first is FSH, number 1.
Correct.
If there is any chance of improvement, say if it is a oligospermia is because of testicular failure, or not testicular failure, but little decrease in the testicular failure, the FSH is going to be high. So here probably there is no role of medical therapy. It's not going to help.
Most important.
So putting them for IVF is a much better option. But if it is FSH is normal, he is obese, then I will go for testosterone and estrogen levels and try to find out whether he is a hyperestrogenic with a lower gonadotropins, that is lower testosterone levels, where probably he may respond to letrozole. If that ratio is more than 10, then he may, less than 10, he will respond much better to letrozole, and you definitely do see improvement into sperm count.
Yes.
So those are the 3 important investigations.
You can give letrozole, anastrozole, and he can reduce weight, and in addition probably just to hold on to him, because every male patient coming from one clinic to another insists on 2 to 3 months of treatment. And when you see that somebody has given a prescription, you usually laugh at it. गरज नसताना दिलेला आहे बघा हे. But still, just to hold on to the patient, it is maybe part of counseling again. And in the meantime, 1 visit, 2nd visit, 3rd visit, then patient starts believing in you. Because males don't believe in the gynecologist of their wives.
I think yes, it does, but I think here it is the first priority is count. Okay, because see, so many times it has been postulated that the varicocele, one of the reason for oligospermia, which is not. Okay, it is a reason for asthenospermia rather than oligospermia. Okay, there is never a reduction in the sperm count because of the presence of varicocele. It is only the sperm which transport through the vas deferens and it goes through the high temperature zone of varicocele. There it loses a motility because of two things. First is a high temperature and second is the oxidative stress which is present because of varicocele. So it affects motility more than count. So Doppler may not help. Ultrasound may help to find out a testicular size. Simple ultrasound. Doppler may not help there probably. Okay, but I think look at your FSH hormonal analysis will probably give more light on its function of the testis, and also using drugs like letrozole, whether it is going to help him or no. So that way, 3 investigation, FSH, testosterone, E2.
Just to add to this factor of varicocele, if you do an ultrasound, quite a few patients will have varicocele grade 1, grade 2. A varicocele grade 3 with symptomatic patient, then only it is to be operated. If the patient goes, I had made one slide long back when I presented, I gave a talk on male infertility. I had made a slide and the font size I had, in that slide, the slide read as who should treat the male infertility. General practitioner, smallest. A gynecologist, a little more. Then surgeon, andrologist, and the largest font I had used for a gynecologist. See, what happens is invariably we send the patient to an andrologist or a surgeon or a urologist. He is interested in only operating. He is not interested whether the patient conceives, regains fertility, the count improves, nothing. Secondly, as Kundan said, do FSH. If it is high, whether you operate on the patient or not, it's not going to reverse. Anything which is 8 and above, already there is an indication it is the highest side of normal. So please, again, this patient will reach, still lower count in days to come. This is, it should be treated as an emergency. And again, these males need a very good counseling.
One more thing I would like to add. The first thing is definitely an FSH. When we do an FSH and it is very high, we know that we are going to counsel the couple for an ART. But along with that, examining the male partner is absolutely important. His BMI is very high. He might be having diabetes, which we definitely have to rule out, and balanoprosthitis, so that when we get sperm collection during FOGSI, so they are not bad. Because the lady has to undergo the burden of FOGSI for a 2 million count. She will have to go repeated cycles if we don't get good embryos. So lifestyle modification and correcting everything, all the hormonal profile and sugars for a male factor is equally important before we subject the couple to a ART.
One more important thing that we should remember is we now have the facility of semen freezing. So whenever you are starting all this treatment, it takes time. To reduce weight, to talk is very easy. But actually to reduce the BMI, it takes a Herculean task, and not many patients are convinced and do the lifestyle modification. So that's a tricky part here. So many times it happens that the counts are like this and the patient is going for multiple trial and error treatments, and by the time they land with ART center, they go into azoospermia. So that becomes difficult. So first thing, whenever I see such patients, I just put their semen sample, 2-3 vials you freeze and keep, and then do whatever you want for 6 months, lifestyle modification, whatever we have discussed. But semen freezing very important, otherwise they land with donor cycles.
And no use of antioxidants for more than 60 days. We have seen prescriptions for male patients that antioxidants are going for 8 to 10 months. Even I think Ashray and Cochrane has come up that excess of selenium and vitamin E, they will have more chances of prostatic cancer. So more than 60 days antioxidants is not going to do any magic. So you have to refer the patient to a higher center.
The antioxidants, there is always a balance between the oxidation and ROS. So both you have to balance. So if you give more of antioxidant more than 2 to 3 months, the risk of malignancies is very high. So never it should be given for more than 2 or 3 months.
So in this case, I would like to, one more thing I would like to add in this. If the male has any habit of tobacco or gutka, that is also very important, because patient will say previously first I have normal delivery, now next time I am not conceiving, but the patient has a habit of gutka specifically, those patients are really having a very less count and the motility is very less. So that is also very important thing.
Yeah, I'll just only come to directly the question. Now this case has been induced with letrozole, and on day 11, the dominant follicle is 19 mm with a minimal collection in the endometrial cavity, and the endometrium.
What will be your take? So that different scenarios that we are given. First is day 11 with a dominant follicle of 19 millimeters. And the trigger, as we have discussed regarding whether to give trigger. Second condition that will be, there is a fluid in the endometrial cavity in this cycle. So how are you going to proceed?
So along with 19 millimeter follicle, she has a fluid in the cavity.
Yes.
Okay. So what is the endometrial thickness? It is good. If considering
thickness is around 7-8 millimeters, but there is fluid in the cavity.
Okay, so no, any measurable fluid is considered abnormal, I feel. So we cannot neglect any fluid in the endometrial cavity. If it is there and she is on ovulation induction with letrozole, so here if the endometrium is 7 millimeter and it is more than 7 millimeter and the follicle is 19, we can give her trigger, we can start her on antibiotics, and after that we can see whether the fluid has disappeared, and we can at least ask her to have timed intercourse.
Yes.
To do or not to do IUI will depend upon the persistence of the fluid. If the fluid is still present, then better to not to proceed with IUI, give her antibiotics, try to clear the fluid, and then only next cycle you can consider doing IUI.
I have a difference of opinion. Actually, endometrial collection along with the hydrosalpinx has detrimental effect, that too in the IVF cycle. In that patient, you have to freeze the embryo, do the clipping or something, and do the frozen embryo transfer. But not in the ovulation induction or IUI cycle. Most of the times it will absorb till the blast is or till it is attached to the implantation occurs. So we can, when the endometrium is good, we can proceed in ovulation induction and IUI.
I think the fluid in the endometrial cavity is always treated is not a good sign, number one. And it is always and always related, more than 90% cases it is related to endometritis. That's a local infection. So if you have a such scenario where 19 millimeter, almost next 2 days she will ovulate and fluid is seen, I will like to put her on antibiotics first. In the same day, I will start her on antibiotics. We will reassess on the day of IUI whether the fluid has disappeared or no. With evidence-based medicine, trypsin, chymotrypsin supplementation is very effective in such scenario along with antibiotics. And you do see it at the end of 48 hours, a disappearance of the fluid. You can proceed with IUI and observe whether fluid comes back. And if it is like 1 or 2 cycles, the fluid is persistently coming. I think these are the patients who are, that 5 days of antibiotics is not sufficient. These patients need a prolonged antibiotics treatment. Of course, what she said is rule out hydrosalpinx. Yes, that I think we will rule out in any scans.
That we have already done.
If hydrosalpinx is not there, then it is the local endometritis is the problem. And prolonged antibiotics is the only thing which works for minimum 2 to 3 weeks. Then it works.
Now the case here another case where on day 11 you don't find a dominant follicle.
I think the follicle is selected but not grown. Okay, so because letrozole has been given, now such patient needs additional ovulation induction, that is gonadotropins. So either next choice is use purely gonadotropin cycles or use letrozole but early introduction of gonadotropins like day 4. So the follicle gets selected, and not only gets selected but it is developed because of the additional daily gonadotropins which is coming. So you won't land up
Will you go for stimulation, I mean with gonadotropins on day 11 in this patient?
No. I will not go here because the follicle is already not in dominance at all.
No, there is no dominant follicle.
Yes, so FSH receptors will not respond to this stage.
Endometrium is thin, there is no dominant follicle. Will you treat it as day 2 and start stimulating again?
No, I will not, because FSH receptor will not respond to your gonadotropins. More likely that she will not develop follicle still.
Okay. I'll go to some other case. Now this case was stimulated, she had a dominant follicle, I wanted to do IUI, I gave a trigger and there is no rupture. Will you go ahead with IUI?
So it is a luteinized unruptured follicle, right? So I think we have to, there are 2-3 things. If the follicle doesn't rupture, there are 2 important points. You have to observe whether that follicle which is 19 at the end of 48 hours when you are scanning, whether it is expanded well or no, because a follicle has to go beyond at least 24-25 millimeter to ovulate. If it is with SCG, the expansion is only 21-22 millimeter, it will still not ovulate. So you are either wrong with the SCG or either wrong with the follicle itself. So even that follicle is defective with receptor level, and it may not even rupture later on, even if you repeat a trigger. So a defective follicle is one problem. Your SCG trigger, probably SCG temperature maintenance is not there. And in realistic LUF, that classical LUF which happens in the insulin resistance and hyperandrogenic patients. So if these patients have not been investigated for insulin resistance, it's better to investigate them, better to give them insulin sensitizers, and they do ovulate. And the last, in this patient now, this patient has got a single follicle, but majority times, rarely it happens that premature LS surge will happen with single follicle. It generally happens with 2 or 3 dominant follicles, the chances are more. Even patient who has already surged and then you have given trigger, it will not ovulate. So these are the 4 important reasons which I will.
So one more conclusion about this slide, which I always tell people, if you are practicing infertility, level 1, level 2, level 3 is not important. But if you practice infertility without doing a ovulation scan, you better don't practice infertility, because these are the surprises. Every alternate patient will show you something, and that what is being called as unexplained infertility is basically actually explainable. There are so many conditions where the endometrium is thin, there is collection, the follicle is not rupturing, and many other things. So a transvaginal sonography on day 2 and 11 and subsequently is most important.
Then I would say we have to counsel him first. We have to explain, because if he is not ready to contribute in the treatment right now, how would he take care of the child which is born? So I would say persistently counseling and making him ready for the semen examination would be very important. Or if it doesn't happen that way, then we can go for PCT.
His mother says that first investigate my daughter-in-law and my son will get investigated later on.
PCT can be done, sir. We can get postcoital test, we can get an idea of the...
Sir, I think counseling is very important here. Okay, I think we do get such patients. We don't mind investigating her before him, but ultimately we have to counsel him that before advising any treatment, we have to investigate him. But I think with diagrammatic representation or illustration, we can make him understand that what is the importance of sperms and how do they, reaching to the oocyte and fertilization. If you make him understand, and if we tell him that if we don't investigate and we'll end up in failure, it might be because of you are not investigating. So I think your counseling points are very important. Ultimately, that husband is going to do that, but your counseling is very important.
There is a great change when I started practice. Almost alternate male refused semen analysis. Now I hardly get one in a year who refuses to get examined. So this was just, a hypothetical situation where the male is not.
Sir, we have to tell them it is just a 50% what your wife is doing and you are the 50%. So if you don't investigate, the further treatment we cannot do.
No, we won't be able to offer you any treatment because we don't know what to offer.
Azoospermic patient with a very high FSH. I won't say high like 30 or 40, but say 12.
So it's a most probably case of, 12 is still it is the testicular failure in the patient is a case of hypergonadotropic hypogonadism. So here we have, depending upon the FSH level, we can offer them TESA, and then if it doesn't work out, if they are not affording, then we'll have to go for donor IUI.
Will you do Y chromosome microdeletion and other things?
I think
before
yes.
you say no TESA also?
No, I think high FSH of 12, still there are chances of focal spermatogenesis. So I think before advising him donor IUI, one micro TSA is worth doing it. If one micro TSA do not give you kind of sperm recruitment, there is a possibility, and yes, Y microdeletion I think is one of the important tests to be done in such patients.
See, this micro TSA is quite expensive. Will you do a needle aspiration biopsy and confirm that there is no?
Needle biopsy.
You may miss
that area. So that's the only problem.
That is true.
That's why micro TSA is more better than TISA.
Okay. So. Anyone? Any other opinion? No? So these are these things, and the cutoff point is FSH 15. 29-year-old married just 6 months, couple in IT has come to seek contraception advice.
She's 29. I feel this is not a very late marriage considering today's scenario, but we have to, as a she is 29, so actually considering recent scenario, this is not a very late marriage, but we have to assess her ovarian reserve before advising them any contraception. Being a gynecologist, I feel her ovarian reserve has to be seen, because we see a lot of premature ovarian failures now. So if her ovarian reserve is good, then we can advise her OC pills, but if her ovarian reserve is poor, then we as a gynecologist, it is our responsibility to advise them to have early conception. That is my take.
I will explain the couple. They should not use any contraception in such case. They should conceive as early as possible because of her age factor and late marriage. Still they insist they want a contraception, then barrier method of contraception.
त्याला अमेरिकेला जायचं आहे, त्यांनी नवीन फ्लॅट घेतला आहे, त्यांना सेटल व्हायचं आहे, काही जण म्हणतात आम्हाला एन्जॉय करायचं आहे. व्हॉट विल बी युअर ॲडवाइस?
अमेरिकेला जायचं असेल then he should, if both of them are going or wife is here and he is only going, then the choice
if he is going alone, then I will not investigate her.
Then we can pick sperm bank, we can keep
I will
the
only
choice.
investigate him. See, the message is many women are marrying late and they still want to postpone a pregnancy. This is a very important this thing. And when I started practice, I was only hearing about PCOs. PCO, PCO, PCO and PCO. Believe me, there are more patients with low ovarian reserve or premature ovarian failure than PCOs. This is what I have experienced in the last 22 years.
Yes, in this patient, first we have to see that is all investigation, their fertility score, that is pre-conceptual counseling. We should advise them what is the scenario, in how many years you have to plan pregnancy, and till that time they can plan with the OC pills or something. But after that they have to
I will solve 50% paper first. I'll do his semen analysis.
Exactly, for semen, a good
do a TVS
and a good aim.
Decide whether they should use contraception.
Sir, but I think if this patient goes to a gynecologist, they'll say it's very simple. You follow barrier contraception, you take oral contraceptive for 6 months, 8 months, whatever time, and then you try naturally. When this patient goes to fertility specialist, then our antennas are on, because we see these cases. So I think approach is different. Of course, the counseling is important, that not waiting for too much time. We see those problems, but I think
what I disagree about one thing. I give this example. I am traveling in my car and driver is driving, and now we go to a hotel, and for me it is a Bisleri, and for him it is a tap water. Is it agreeable? Do you agree with this? If a patient goes to a gynecologist, he or she will say, wait, do this, that. If a patient comes to IVF, why the difference? Why any practicing gynecologist should do this simple test and decide?
Sir, I think one of the important point is that a contraception is a patient choice, number one. If she has come to you for a contraception, your decision for contraception has to be respected. That decision is patient's, number one. Your point is valid and well taken that yes, nowadays we see young low ovarian reserve patients and asking them not to wait for too much time. Worthwhile examining them by transvaginal scan and okay, you see reserve. But I differ only for doing those extra test, semen analysis and all those for contraceptive advices. If the reserve is fine, they can take 6 months, 1 year, no problem. Okay, but I think that decision they are there with you for a contraception. Okay, they are not there for the fertility, and they have a full right to plan their life.
Agreed.
Because they may not take, they are not here with you, okay, I want contraception for 5 years.
Agreed.
Right, so that's my only point.
Yeah.
That is the counseling. That is counseling from our part.
This was done for years.
Is a personal choice.
What you said, Kundan, this was done for years. Even patients who had an abortion, a pregnancy loss, were advised to abstain for 1 year. See, when we started knowing more and more about the endocrinology, about transvaginal sonography, antral count and all those things, now this is high time that we also adopt this policy. Patient has come for contraception, yes, agreed. But you are not like a shop, mala te dya jara 5 rupayacha. Tasa nahi hai. Here patient has come for advice. See, I think we go one step ahead and tell them it is not advisable, but it is your choice.
Yeah, we have to give them an informed choice after doing a good TVS and a semen.
Okay. Now, the good news is this is the last slide. Now, this is the actual patient. Why I have included this patient? Many people did not know how close they were to their goal before they abandoned the treatment. Abandoned the efforts. If they had known that they are very close, they would have probably gone ahead. This is the message. Now, this was a 20-year-old girl with a BMI of 21, married 1 year, lot of social pressure from the family members and the relatives. She was a known hypothyroid. She used to bleed only on withdrawal. HSG showed bilateral spill. Husband factor normal. Her AMH was 5.62, bilateral PCO. We did her HOMA IR, just to document whether she is insulin resistant. Optimized for 3 cycles. Planned induction of ovulation with 2.5 milligram of letrozole for 5 days. HMG 75 on day 8 and 9. On day 11, the endometrium was thin. There was no dominant follicle. This I had already asked what next.
Here.
There are choices either.
Sir, I will not treat this patient because she is 20 years old. I will not treat this patient because she is 20 years old nowadays. Because ART law doesn't allow us to treat her.
No, 22.
20.
Okay, if she is 22, then it's my approach is different. Because it was 20 years written. But I think this patient has not responded to letrozole and HMG given on day 8 and day 9. Plus, she looks to be, I think if she has not received metformin, then it is worthwhile giving her metformin for at least 2 cycles before you start any ovulation induction. And when you do ovulation induction, I prefer giving letrozole only for 2nd and 3rd day and introducing gonadotropin right from 4th day.
This cycle was taken after she was optimized for 3 months. Now day 11, there was no dominant follicle.
So early administration of gonadotropin. So the protocol for such patient is give 2.5 milligram letrozole on 2nd and 3rd day.
Fine.
And 4th day you start giving her HMG, either 75 or 150. Even 150 is no problem. And also to downregulate them by 1 cycle of OC pills in previous cycle. She will respond.
Okay.
It will never happen that she won't respond.
Since I had not met you, I did not know this. So what we did? कुठे गेले ते पुढे आहे ना. So we started her with 150 milligram, 150 IU for 5 days on that day. Then on day 16, she came us, we did her E2, it was 59, no change in TVS findings. So we increased the dose to 300 for 4 days. On day 20, her E2 was 191 picograms, the endometrium was 10, and now she showed a follicle of 16. We gave one more HMG and called her on day 21. She showed a follicle of 19. We planned the trigger, SCG 10,000 plus luprolide 1 milligram. Did IUI after 48 hours, gave her luteal support. 13 days after, she came with a UPT positive. 1 week later, she had a single intrauterine pregnancy.
Sir, but you have spent 25,000 rupees on HMG.
Agreed. Now, see, there are 2 things. She must have taken treatment already. In a stimulated cycle, day is not important. That's why I said, you may be near to the goal, you have to persist with the stimulation. I would have abandoned this case only if she had failed to respond to 300. Or the E2 had not risen after giving 150 for 4 days or 5 days. See, I agree that she has spent, but she was a bad PCO, and patients, we know that, see, you can induce and you can do it for 21 days also. Now, we treat chronic low dose regime where you give it for 25 days and you get a dominant follicle, 1 follicle. I mean, Unifollicular, monofollicular development is also possible. I don't say that every patient can be, taken up like this. This is not a sort of a, this case is not presented here to tell that every patient should be taken like this. But sometimes what happens is, on day 11 or day 13, we think we abandon the cycle. Already whatever treatment she has been given is a waste. So you continue. In good faith that the patient is likely to respond. Sorry, this was the last slide. Thank you.
Thank you, sir. Thank you, Vijay, for excellent moderation.
Yeah.
Thank you.
Thank you everyone for this wonderful discussion. I request Jamma ma'am to please felicitate our moderators. Vijay Pawar sir, Dr. Doshi sir, please. I request Doshi sir and Vijay Pawar sir and Jamma ma'am to please felicitate our panelists. Dr. Revati Rane ma'am, Dr. Supriya Birazdar, Dr. Hasina Sheikh, Dr. Meenal Chidgupkar, Dr. Kundan sir, Dr. Rajesh sir, please join. It's a great privilege to give vote of thanks on behalf of my team. Thank you, Dr. Rishikesh Pai sir, FOGSI President, and Dr. Anjali Jamma ma'am. I am thankful to our esteemed faculties, Dr. Kundan Ingre sir, Dr. Charulata Bape madam, Dr. Rajesh Darade sir, Dr. Bahubali Doshi sir, Dr. Vijay Pawar sir, Dr. Revati Rane madam, Dr. Meenal Chidgupkar, Dr. Hasina Sheikh, Dr. Supriya Birazdar, for this great academic feast. Thank you our seniors, my colleagues and friends for attending this workshop in large numbers. Thank you Balaji Sarovar for the best venue Mr. Shedzale for best audio visuals, Mr. Mohan for photography, and Mr. Ivare for helping us to make this CME a great achievement. Last but not the least, the most important Alembic Pharma and team as our academic partner. Thank you. I request everyone please to join for a delicious lunch.